That's
Now-
only on the torso.
What's that?
On the torso.
Anywhere.
Anywhere?
Anywhere. Okay. Like, who had the neck one? You did. Yeah. So that's going to affect his neck, but we'll do that tomorrow. Okay. Tomorrow is neck. Okay. So let's go. Let's look at psoas and QL. Okay. Who is my guinea pig for psoas? Yana. John. Yana or John?
Jana.
Janet. I'll get it. I know it's right side. So head up there. Tom can move. Okay. So she had left-sided, right-sided low back pain. She kind of pointed in the area of her QL. So this, we're going to start this way. And remember, I haven't corrected anything, right? So breath in and out, meet my pressure. Strong in the clear. That's how she started last time, right? Go to the QL. This is relational compensation. Meet my pressure. Yes. And back to here. And meet my pressure. And she goes. Okay? Now, TL, your right side where it hurts. So now we're seeing if there's a relationship between the psoas and the QL. Breath in, out, meet my pressure. Good. So yes, there is. And because it started strong in the clear, we know that the QL is facilitated and the psoas is inhibited. Okay? So now, turn on your side here. Okay. Alan, I'm going to let you be the star of the show. Do your favorite QL release.
I'll have her stand up.
Okay, have her stand up.
Stand up for me. Come right over here. Feet apart. Just
Move the
a little
camera, Tom.
bit. Okay, so we're looking at right QL, correct? Okay. All right, so what I want you to do is shorten this way. I'm going to have you do in a second. You're going to pick your arm up. I'm going to have you bend straight over to the left, like that. If it's hurting, let me know, okay? So start bend to the right.
She probably want to be over there.
Okay, and I'm going to grab onto you so I don't push you over. You pick your arm up over your head, bend all the way to the left. So keep there for a second. Am I okay? My pressure's all right? Okay, and then come back. Okay, and then bend a little bit to the right, the starting position. Good. Pick your arm up over your head. Over. Good, and come back. Still okay, right? No pain.
Good.
Okay, then go again. Pick your arm up, over, hold it. Okay, we're going to do one more, maybe two down at the bottom. Okay, starting to the right a little bit. Pick it up. Good, that feels pretty good. Let's see if that's enough. We can test it out.
Okay? Thank you very much. And remember, if you're a non-manual therapist, you could do the exact same thing with a ball. Okay? So don't worry about that. NKT, you don't have to be a manual therapist. We have trainers and Pilates people all over the world doing it with non-manual techniques.
So palpatorally, it didn't feel like a very tight QL.
I
Yeah.
know, she's got incredible range.
Yeah.
I'm hypermobile.
People who are hypermobile will be that way. All right, so breath in, out, hold up. Okay, so whatever you did works. But now we have to challenge it. Breath in, out, good. And then breath in and out. Good, okay. So that's QL to psoas. So what would her homework look like? She'd roll out her QL, 2 tennis balls in a sock. She certainly can't do it by stretching. She's too mobile. Okay? So 2 tennis balls in a sock. You find the sore spot and you roll it out.
Okay.
Okay? Now, how's she going to activate her psoas? That is the question. Okay? I'm going to have her do this. Then I'm going to have her put her hand right here. And I want you to lightly resist the inside of your knee moving towards your left shoulder. Hold for 5 seconds and repeat 20 times. You feel your psoas engaging? Exactly. Other things will engage with that as well, not to worry. Your internal oblique will engage with that as well. Yeah.
So in her case, she had the scar, right? Didn't she?
No.
She didn't have a scar.
No scar.
Okay, and so the go-to for the low back pain is it always going to be the psoas?
No.
So I wonder why we
It
didn't
could
pick
be
erectors
abs.
or QL or abs, right?
Yeah.
So I wondered why you selected that.
Because I wanted a good example of QO to psoas. Yeah. Now, and it can be any number of things.
Yeah, I just know how you picked where you're going to start
Lucky guess.
with a low back pain
It was a
patient.
lucky guess.
So if something hadn't changed, like you,
Then I know I'm not on the right
You just tried
relationship.
different pattern.
Exactly, exactly. Yeah. All right, thank you very much. So you saw QL and psoas? Yes. We looked at abs and we looked at scars. We looked at, what haven't we done for this? I think we've covered, have we covered all the muscles of the, yeah, we have. We're not going to do obliques, that's level 2. So, glutes. Let's do glutes. Yeah? Who's a glute person?
What do you mean?
no, I
glute
was
person?
just excited there was something in level 2.
Okay. Who has lower back pain and suspects that their glutes may not be working so great? Olga, come on up. Okay. So Olga may have dumbass syndrome. We're going to find out. We'll find out if she's a dumbass, half-assed, or smartass. Alright? Those jokes went over really well in Taiwan. That's how I broke. You remember, Jordan, how I broke the ice there with the ass jokes?
You had to refine yourself.
I did. I had to find a way to make them laugh. Yeah. That opened up the door, though, the ass jokes. It was great. All right. So the glute max, remember, has a lot of oblique fibers. So you want to test it with the foot slightly turned out this way. Now, this test is a lumbosacral test. When you test it off the table, it gets to be more of a butt test. Okay? But let's do both because they're important. So breath in and out, need my pressure. So Olga's right, they ain't working. Breath in and out, need my pressure. Yep. She's definitely half-assed for sure. All right. Okay. So let's see about what might be compensating. What's the history of it? Any back pain, any hip pain,
Lower back pain.
all lower back pain?
Yeah, SI joints. both
SI
sides.
joint on both sides. Now, a little birdie told me this, but I think the gluteus maximus may actually cover part of the sacroiliac joint. I'm not sure about that, but I think it does. So, if a muscle that's associated with the joint, like the glute max, doesn't fire properly, what does the joint do? What does it
Locks
do?
up.
It locks up to create stability, right? Because your brain's going, help, help, help. I feel unstable. Okay? So put your hand on your right SI joint. Take a breath in and out and meet my pressure. And there you have it. Okay? So tight SI joints commonly associated with weak glutes. Okay? And let's try again over here. Now, if the joint TL makes the glute stronger, that joint is always going to be facilitated. You don't have to worry about directional tension. Okay? So breath in and out. Yep, she's a dumbass. All right. Grab that other SI joint and meet my pressure. Yep. Okay. So it's bilateral SI joints to glute max. Okay. So would that SI joint be compressing itself or decompressing itself? Probably compressing, right? So then the question is, how do I decompress an SI joint? Okay? And the answer is, all you need is a yoga belt or a long belt. That's all you need. Okay? So, pardon me while I take my belt off. Is that politically incorrect? I hope so. Those people have no sense of humor. All right. I can make all kinds of jokes, but I won't. All right. Lift up here. Okay. So the belt, and in the office I use a yoga belt. It doesn't matter. So the belt, here's the top of the ilium. right? You want to be right in the middle of the ilium so you can get a good purchase on the ilium. Okay? Turn your foot in, right foot in. So that helps gap the SI joint. And then gently pull. Do you see? Just to get a little bit of internal rotation. So if the butt comes off the table, you're stretching the piriformis, you're not decompressing the SI joint. So this is very subtle. Okay? So a little bit of pull, 5-second hold, and you're going to have the person repeat that 20 times. This would be part of their homework. Okay?
And how would they do it to themselves?
Just like this.
You're just trying to create space in the SI joint?
Just like that. It's my wife's idea. I have to give her credit once in a while. Jeez. Come on. She never gives me credit, but I have to give her credit.
She's not here to confirm it.
Yeah, no, of course.
So because of her symptoms, did you have her do it on both sides then?
For her, it would be release the right, activate the glute, release the left, activate the glute. Because each side requires a separate protocol.
Okay.
So if you did release, activate, no reprogramming.
Okay.
Good question. Thank you for bringing that up. You get a gold star for that. Okay? So I only did it a few times. And then if they mouth off, you can always beat them with the belt. You know? It's a multi-purpose use of the belt. All right. Bend your knee, breath in and out. Read my question. Got it. Okay. And if I did that to the other side, the same thing would happen. So this kind of homework for the sacroiliac joint is fantastic. Okay? And glutes can also affect the neck. Remember, the back of the neck. They can affect the hip flexors. They can affect a lot of things of glutes. Plantar fascia, the calf muscles. So having functional glutes is a really, really good idea. Especially with people sitting so much these days, glutes have become very lazy. Very, very, very lazy. And we're seeing all kinds of problems from that, right? Any questions about that?
I have a question about the reps, or the homework that you give folks. So you had mentioned something about instead of giving them a number to say, do this until it feels fatigued.
But that's an actual exercise.
Yeah.
This is a release of the sacroiliac joint.
Gotcha.
But if it hurt, let's say at rep 17 it started to bother them,
Right.
you
And
would only
stop
do
there.
16.
Right.
Yeah.
What if they get hung up on one day they do it this amount and then the next day they do it less instead of more? Do that? You know what I mean?
That screws up everything, yes.
Yeah.
Yeah. Human nature is when I feel better, I stop doing my homework.
Right. Right.
You know how many times I've had to fix people who stop doing their homework?
Yeah.
Yeah, so the absence of symptoms does not mean you cured anything. It just means you have symptoms that are not bugging you anymore.
So when do you know when to stop doing the homework?
By your
Because-
they come back for a reevaluation and you know.
Okay.
Yeah. But a lot of people only see me once, probably because of my lousy jokes and stuff, right? And then they get fixed, right? Because they do their homework. So oftentimes I only see people one time. A lot of people say to me that's a bad business model. I say it's a great business model. I get a lot of referrals that way. Yeah. Okay, you can stop, Tom. Thank you.
Hi, this is Eric Nelson, board-certified sports chiropractor and neurokinetic therapy instructor. I'm very excited to introduce a new protocol that we just started teaching in our Level 1 classes. This protocol will help you get more accurate results with your patients and clients so that they'll get better quicker. The protocol's name is called ABA testing. It's a variation of testing that we do in Level 3. And as I said before, it'll help you get more specific with your findings. Traditionally with NKT, we tell you to look for a weak muscle, muscle A, and then we have you look for a second muscle, muscle B, that when you therapy localize it, it causes muscle A to become strong. We then call the weak muscle inhibited and then the strong muscle facilitated. We'd have you treat the facilitated muscle and then activate the inhibited muscle. What we're finding though with our Level 3 protocols is that sometimes the relationship is actually opposite, where the weak muscle is actually the facilitated muscle and the strong muscle is actually the inhibited muscle. So with this new ABA protocol, you could determine the direction of dysfunction. Now there's 2 steps to this protocol. One is doing exactly what you've been doing. Find a weak muscle in the clear, then find another muscle that when you therapy localize it, causes the first muscle, muscle A, to become strong. What we've done here now is determine that there's a relationship between two dysfunctional muscles. The second part of the protocol is to fire up muscle B, and it doesn't really matter what happens if it's strong or weak, but what matters is what happens when immediately after you fire up muscle B, you go back and fire muscle A. If muscle A stays weak or gets weak, that's the inhibited muscle. If it stays strong or gets strong, that's the facilitated muscle. Pretty simple, 2 steps. Let's do a demonstration. All right, so in this case, muscle A is going to be the glute max, and we're going to test it here. So press it in my hand here, and you can see that it's weak in the clear. I'm going to have her therapy localize the iliacus, and then so that would be iliacus is muscle B, and then I'm going to have you press down, and sure enough, muscle A is now strong. So now what we've determined is that there's a relationship between 2 muscles. So now we're going to do the second part of the protocol, which is to determine the direction of the dysfunction. So we're going to fire up the iliacus, and again, it doesn't really matter what happens with the iliacus, and then we're going to go back and fire up the glute max, which in this case you can see is now strong. So as I said before, if muscle A gets strong or stays strong, that's the facilitated muscle in this relationship. So thanks, Cal. So you can see by simply adding a step, we can determine the actual dysfunction, the direction of dysfunction. It's a pretty simple protocol, 2 steps. 1, traditional stuff you've done with NKT, that just tells us that there's a relationship between 2 dysfunctional muscles. And then second part, fire up muscle B, then go back and fire muscle A, and whatever happens to muscle A determines the direction of dysfunction. If muscle A is weak, if it stays weak or gets weak, that's our inhibited muscle. If it stays strong or gets strong, it's our facilitated muscle. That is ABA protocol. I know that if you jump in and start using it with your patients, you'll see some amazing results. Thanks a lot, and I'll speak to you soon.
Yeah.
Okay, so you have medial epicondylitis. Show us where it hurts.
I feel it more like just above, like kind of in the triceps where it could be tender, but
Yeah.
it's kind of like with any kind of flexion, throwing.
Yeah.
You know, it's like it
Do
feels
you do
like
pull-ups?
no,
you
but,
ever do pull-ups?
but no, not really. But I play softball,
Okay.
throwing,
Okay.
batting.
Yeah. Okay. Head up here, line your back.
You have badass arms. I just want to say that.
Yeah.
Thank
you
you.
know.
No, it's,
They're toned.
it's good. Yeah,
They're
it's
toned.
good.
They're toned. Okay, can everybody see? Get close. Come on. So here's the medial epicondyle, and it's the meeting place for wrist flexors, finger flexors, and also you have the pronator teres here too, right? So a lot of stuff is meeting here. So anytime a place has lots of muscles crisscrossing it, there's a greater potential for dysfunction. So lateral medial epicondyle of the elbows, you're going to have lots of people have issues because of all the crisscrossing. Okay, so I'll palpate in here and she'll tell me where she's a little sore. Mm-hmm. Right there.
Yeah.
So this is a good spot for medial epicondylitis. Okay, this qualifies. Right.
Isn't everyone sore there?
No,
Yeah, I'm good. Really? Yeah.
I don't hurt there. No.
Okay.
Speak for yourself.
I'm speaking for myself.
Okay. Now, everybody take their arms out like this. Okay. And I want you to tighten the inside of your elbow and pull in towards your sides. Puts a lot of stress on your elbow, right? Now go like this and use your armpit muscles. Squeeze your armpits and pull in. See how it takes the pressure off your elbow? So people who end up, but medial epicondyle, anytime there's an elbow problem, it's either a shoulder problem or a wrist problem. It's never an elbow problem, okay? So the elbow is the symptom, not the cause. So we have to figure out where the problem is, okay? So with medial epicondyle, I like to look at adductors of the humerus. Okay? So let me test them in the clear. Hold your arm in against your side. Take a breath in and out, and meet my pressure. Tell them how that feels.
Like there's nothing going on there. Nobody's home.
Nobody's home. That's a good way to describe it. Okay. House is locked, lights are off. Shall we do a burglary? Okay, good. All right. Breath in and out. Meet my pressure. Yeah. So that's definitely related. Okay. And now we need to fire this up so that we can retest the adductors to see what's up. Okay? So I'm going to have her flex her wrist and meet my pressure here. Okay? Meet my pressure. Flex. Flex your wrist and keep it. Yeah? Okay? So that gets the medial epicondyle fired up. Okay? We'll go back here and retest the adductors and meet my pressure. And there's absolutely nothing there. So, when you're throwing a ball and you don't have humeral adductors, that could be a problem. It hurts. Okay? So, to throw a ball, you need some adductors. Last time I checked, like PAGs and the whole UCF here would be helpful when you're throwing a ball, right? Rather than your elbow. That's always one of my favorite questions on Facebook. You do know the pec minor is not attached to the humerus. Really? I never knew that before. Wow, thank you so much. Try throwing a ball without your pec minor contracting, I always say. Oh, yeah. I guess I never thought of it that way. Yeah, because cadavers don't move.
Body's in motion, they do.
It'd be nice if people thought about living bodies instead of dead bodies. Right? All right, ready? Breath in and out, and meet my pressure. There it is. There's your arm. Now, imagine how much better you're going to throw.
Yeah, excited and less pain.
Yes. So first you're going to release here, right? And then you're going to do some pulls into your side like that. Not using your elbow, using your armpit. So you're gonna, that's the idea. That's what you're not doing when you're throwing.
How different is that from the lat test?
Not that much different. But remember, the lat test is still a functional test. We just name it that way.
Mm-hmm.
This is another version of that, right? This is just this way instead of that way.
So, am I using...
Your armpit, whatever's in there. You're squeezing here, and you're squeezing back here. Anything that adducts you're using.
So that
Okay.
her homework would be contracting her armpit?
Correct. Pulling her arm this way.
Okay.
Not using her elbow.
Not as specific.
Bare band.
It is specific,
You put the band above the elbow.
right? You're holding the band. You hold the band.
I'm sure when I do that.
Hold the band. Pull in.
Okay.
Use
I'm
your
not
armpit.
arguing.
Yes, you are. I'm not arguing, counselor. Yes, you are.
Oh.
There. Thank you, madam. Now, anybody have lateral epicondylitis? Anybody ever have lateral epicondylitis? Okay, Sonia. Which side?
Right.
Oh, we're in heaven here. All right.
Oh, right.
You're good.
Tennis player.
Yep.
Are you a tennis player?
Aerialist.
So, when does it hurt? When you grip something?
It's almost toned down now, but picking things up,
So grip.
twisting, gripping,
Yeah.
gripping, extending.
Did I fix it when I was working on this?
Okay. So, let's talk about the muscles that make grip. Okay?
Okay.
We have intrinsic muscles within the hand itself, and we have extrinsic muscles in the forearm. All right? So when you grip, everybody grip, you can feel the muscles in your hand, right? The thumb and the pinky squeezing together, and then can see your forearm muscles popping out, right? Those are the muscles that make grip. So there's a balance between the extrinsic muscles and the intrinsic. If the intrinsics don't work, the extrinsic have to work harder. Okay? So here's my favorite test for intrinsic grip. Thumb to pinky. This is called the opponent's test because this is the opponent's pollicis. and this is the opponent's digiti mini-me. And it's actually pronounced that way. I'm not actually making that up. I'm being serious on that one. Okay, so thumb to pinky, pinky to thumb, meet my pressure. Negative, right? TL your lateral epicondyle where it hurts. Got it? More or less. Hold these two together now. So your grip's living in your elbow instead of in your hand.
That hurts.
Yes.
Yeah.
Okay. People always ask me, how do you figure this stuff out? I did it to myself. I just thought,
You TL'd yourself and then tested yourself?
that doesn't sound right.
Okay.
Right there?
Oh, yeah.
So lateral epicondylitis can be a pretty bad problem. People can get some very, very serious inflammation here. So a little bit at a time works really well. Okay? The other possibility for lateral epicondylitis is weakness in the shoulder. So weak anterior deltoid test normally goes with this, if it's a shoulder problem. Okay? And then gripping problems tend to go with that thumb to pinky test. One of my faves. Grip up, take your hands up and look at and squeeze your thumb and pinky together. Don't touch them together, but kind of contract. And see if your pinky muscle actually has some depth to it. So it pops out. If your pinky muscle doesn't pop out, you may have some problems with your elbows eventually. The opponent's digiti mini-me. This one here. Yeah, exactly. Here's her. All right. Breath in and out. Beat my pressure.
Not a big deal.
Good. Push your pinky into your thumb. Beautiful. Squeeze my hand. Now, use your pinky towards your thumb. Go. How's your elbow?
Fine.
Good. Now, I'm an object. Try and pick me up.
Yeah, that feels like there's muscle.
Good. Good. That's your homework.
Dig in there and then
Push your pinky into your
push my
thumb.
pinky in.
Exactly. You got it. Okay?
Okay. You can meditate.
Yeah. That's right.
Only on
You
the
can.
one side.
They're both like this one. There's nothing over
question.
there.
Going back to what you said before, you said if it's a gripping issue, it's usually thumb to finger, and
If it's a shoulder issue, it's somewhere up in here. Anybody else have lateral epicondylitis? You might have a shoulder issue. She's actually does. Who else?
Did you raise your hand?
Nobody raised their hand back there.
My
You
elbow
were pointing at
snaps when I do dips. Like
That-
here it pops.
That's what we had in the first example with that was the medial epicondyle with the lats. So you got to get your lats working better. Dips and
It's on
elbow.
the lateral.
Oh, it's a lateral?
Yeah.
Oh, come here.
So much more.
Left side or right side? Left. Oh. All right. Michelle, good. Go. So he's saying that when he does dips, his lateral epicondyle is snapping. Okay? So let's see what he does. Let's see about his shoulder muscles. Let's see how he does. Breathe in and out. Keep my pressure. He's a big, strong boy. That wasn't a very good test. Let's go to the other side and meet my pressure. That's a huge difference left and right. Okay? So I'm going to TL here on the lateral epicondyle. Okay? Redo this test. And there it is right there. So when you're doing the dips, your deltoids aren't engaging and your elbows are overworking. That's all that is. Coach. All right? So when you use the wrong muscles or the wrong joint, problems happen. Shoulder's a big, strong joint supposedly, right? And then the elbow has taken on. Elbow doesn't like that very much. Okay? And meet my pressure. Good. Yeah, so that's the key. Okay, so release here, straighten there. End of discussion. All right, you can stop it. Okay, so here's flexor pollicis longus. You have to do the resistance at the distal joint. Okay, and meet my pressure. Don't bend your thumb, straight. Good. Now bend your thumb this way and meet my pressure here. Flexor pollicis brevis. Longus, brevis. We use our brevis a lot to do manual work, right? Okay. Here's extensor pollicis longus. And bend the thumb. And here's extensor pollicis brevis. Now he has one. This is one that I commonly find not working. Try pulling your thumbs back like that. That's your brevis. That's the functional opposite of when we're, poking like that, right? So lots of people have problems with that extensor pollicis brevis. Here is flexor indicis. That's where the word indicate comes from, right? And extensor indicis. Okay. This one does not have a name, but you already heard it. So this is flexor flippicus and extensor flippicus. If people's extensor flippicus muscles are not working, I take their driver's licenses away. Where I come from is a turn signal. All right. And these two fingers I do together because fourth finger generally doesn't have good control unless you're a violinist or a pianist or something like that. So need my pressure here. This one I renamed because it doesn't have a name, it's just digitorum. So I named this Hitchicus. So we have flexor Hitchicus, extensor Hitchicus. And then this one is actually digiti minimi, of course. So we have flexor and extensor digiti minimi, but I renamed this Picicus. So we have Flippicus, Hitchicus, and Picicus. All right? I like those names better. And they talk to their function anyway, right? Yeah. They're functional names, right? Yeah. Okay. So people who have carpal tunnel, you will find a lot of deficit in finger extension. A lot. Thumbs, index finger, it could be anything, all of the above. All of them could not be working. So then it's important, one at a time, you get a rubber band around the thumb, okay? You pretend you're holding a rubber band out here. He's going to take that around his thumb and he's going to pull his thumb back against the rubber band to activate the extensor pollicis. He would do the same thing with the indicis, etc., etc., etc. So you want to do one finger at a time to get motor control, right? If you do them all at the same time, which is what some of the devices do, they make you do all your fingers at the same time. Where does the brain always go? The path of what?
Least resistance.
And so if one of the finger extensors is stronger than the other, which one is the brain going to pick? The strong one, which is why you can't do big exercises when you have a motor control problem, because your brain is going to go right to creating more of a problem than you already have. Okay? So we want to isolate things as much as we possibly can, so that you get motor control over that particular deficit that you have. Does that make sense to everybody? Mm-hmm. Okay? All right, good. Okay, we're done. So breath in and out, meet my pressure. Nothing. We know that she has a relationship between her neck and her glute. Turn your head to the left. Active therapy localization, left side of her neck, meet my pressure. Glute fires, she turns to the right. Meet my pressure, and it takes the left side of the neck out of the equation. Now we know that there's a relationship somewhere between the left side of her neck and her glute. We didn't know exactly where. So touch the base of your skull on the left. We'll walk down the circles. Okay? Breath in and out, meet my pressure. Note, mid-cervicals now. And meet my pressure. Lower cervicals. Meet my pressure. How about if I do upper tract?
Mm-hmm.
And meet my pressure. Yeah. It's in her upper trap, which of course becomes your neck, right? So her upper trap and her glutes have a relationship. Okay? So we'll let your friends work on you to release your upper trap and strengthen your glutes. But everybody get the idea? Okay? Now, we would have to do directional testing on this because she was weak in the clear, right? Okay. So here's the upper trap test. Does that make sense to everybody?
Okay.
Meet my pressure. Good. And now we'll retest the glute and we'll see what happens. Breath in and out. Meet my pressure. It won't matter. There ain't nothing there. So her trap is facilitated and her glutes included. Okay? So when we lose the glutes, neurological connection to the glutes, it's a central, powerful, centrally located muscle, like the psoas and the abs. Your brain goes crazy with that stuff because it's losing core stability. It will compensate as much as it needs to, as much as it possibly can. Okay? So you will see global compensation patterns emerge from psoas and glute weakness. Okay? This is one of the most common examples. This morning, we had a couple people with neck stuff to psoas, right? What's going on there?
It's the door to the
These
outside.
other doors opening.
Really?
It creates a vacuum.
So glutes will have the same effect on the neck, only posteriorly, that the abs and the psoas have on the neck anterior. Okay. So we looked at glute, we looked at iliacus. Let's also look at, while you're there, I'm going to borrow you for some other tests. Okay? Let's look at the rest of the hip flexors. Okay? So hold your leg up like this. Take a breath in and out. And meet my pressure. Okay? That was your rectus femoris or rectus zeroforis. There was nothing there, was it? Turn your head to the left. Okay? Breath in and out. Meet my pressure. Wow. Her poor neck. All right. Look straight up. Okay, so what other hip flexors are there? There's the psoas, right? And meet my pressure. Turn your head to the left.
Oh boy.
Meet my pressure. Okay?
My neck's doing everything.
Your neck's doing everything.
It hurts.
Yes, I know. So we'll get into why this happens in just a minute. Okay? Here's sartorius. So press your knee down here and pull your heel to your crotch. Ready? Breath in and out. Meet my pressure. Press and pull. Okay? Turn your head to the left. Press down and pull. Okay? One more hip flexor to show you. Tensor fascia lata. Breath in and out. Meet my pressure. Turn your head to the left. Meet my pressure. So her neck is working for everything but her. Well, we didn't test the iliacus to see. Breath in and out. Meet my pressure.
Pushing this way?
Yeah, you are pressing right here. Meet my pressure. Turn your head left. And meet my pressure. So every hip flexor, her hip extensors or hip flexors, the whole deal or whole hip on that side, being compensated for by her neck. That might create some neck pain. What do you think? Think that might do it? So this is one muscle compensating for many, many, many. Okay? We also have the reverse, where one muscle causes many, many, many dysfunctions. Okay? That's what this is. We also have where multiple muscles are compensating for one weak one. Okay? So it can go either direction. Another thing you need to know is that the QL could be inhibited in one relationship, like to the other QL, but it could be facilitated to the psoas in another relationship. So, because a muscle is inhibited in one relationship or facilitated in one relationship, does not mean that it's that way in every movement pattern. It's just specific to that movement pattern. That's why the testing is so critical. You have to be able to distinguish one movement pattern from another and not assume that a muscle that tests strong in one movement pattern is going to do that throughout all movement patterns. Everybody get that?
Yeah, I have a question.
Yes.
Were you assuming that it was the upper trap for all of those, just because you did test it originally when you were testing it?
I just showed you an active therapy localization.
Okay, so you don't know for sure exactly what in your neck is causing this?
Correct.
There are other things that come in the neck this way. Right, but he just tested the upper trap, so I just want to make sure, because I'm trying to be global.
Are you into global economy? Or local economy?
Well, that's an interesting question.
Okay, we won't answer that.
Oh,
All right.
that's right.
So I don't know. I'm going to guess that it's
By
probably
local.
It's probably the same spot for everything.
Well, I wondered.
Yeah.
Yeah.
It probably is. But the point being that one spot can work for many, many, many others. I tested somebody once for diaphragm. She was a water polo player. She was having quote-unquote asthma, which wasn't asthma. Her diaphragm was facilitated for 30 different patterns. 30! We cleared out like 25 of them in the first session. She felt, And then we did the second session, and she went back to playing water polo. And then her father says to me, I just spent like $10,000 on testing her for all this bullshit. Why didn't I find it? I said, well, I would have taken the $10,000. I'm real proud. So, this is an example of how one muscle can get so loaded up neurologically because of its relationship kinetically to the lower body. So you can have neck to lower back. You can also have lower back to the neck. It can reverse as well, right? So don't make assumptions. Test, don't guess. Test, don't guess. Test, don't guess. All right?
Sorry, I have one more question.
No, you don't. I can sense that there are many more about that.
That's a good question.
Let's assume it was the upper trap and it was facilitated and you treated it. Then do you test each one and go back, or does it kind of unravel and then all of them will start working together?
Well, that's a great question, actually. So I'll actually...
That's right. Thank you.
Your Honor, I'll allow that question.
Okay.
All right. So let me release the upper trap. Okay. And then this is actually Holly's question is really good because how could you possibly? No, they're not. How could you possibly assign that much homework to somebody? You wouldn't want to do that, would you? Because it's enough to do one release and one activation. That's all I ever give. So now we have to prioritize. You having fun? Mm-hmm. Okay. Now we have to prioritize which is the weakest muscle so that she can then release the trap to the weakest muscle. Because some of these are going to clear up and some are not.
And could you tell when you tested it which one was weaker or not?
They were all
just weak.
Completely gone.
Did she say her pain was on the left side?
Yes.
Okay. Is that why you didn't get too curious about the FCM?
Oh,
it's not new.
It's messed up too.
Well, we'll start with one thing.
Okay.
All right. Now, to challenge this, turn your head to the right. Because remember, everything just blew out as you turn your head. Okay? So, breath in and out, hold your foot down. Better, right? Mm-hmm. You turned. Breath in and out, hold your leg up. Okay? Breath in and out, lock your knee, hold your leg up. Good. So far, so good. Okay? Press down here, pull your heel to your crotch. Sartorius, still poopy. All right? Iliacus, press here. Good. Here. Press out towards me. Good. So, Holly, What's the homework? Release the trap and activate the...
Yes, sartorius.
Correct, and that's how you prioritize.
Okay.
So that was a great question, thank you. All right, now you may stop the video. Okay, so let's test the RecFem, and the purpose of this is to show you how to make your muscle testing more specific, okay? So if I test him in this position, this is kind of the middle position of the hip joint. If I go all the way up here, that's closed, right? And if I test him down here, that's the open position of his hip joint, correct? So we have a little expression, OPCD, not OCD, OPCD, open, proximal, closed, distal. Open, proximal, closed, distal. So this is the open position. If I have him press up here, I'm testing these fibers here. If I have him close and I have him to press here, I'm now testing down here. Okay? That's OPCD. So if I wanted to test very specifically the fibers of his RecFem that attach to his knee, I would test them in this position. Okay? That make sense? All right. Now, the RecFem, like many other muscles, has medial, middle, and lateral fibers. Okay? So we want to be able to test all of those. And of course, as everybody's pointed out, yes, they have the same motor nerve. But do they have the same sensory motor nerves? Negative. Okay? And we're testing sensory motor. All right? So if I want to test the medial fibers of the RecFem, I'll hold the leg up like this with the foot turned out to expose the medial fibers. So breath in and out, meet my pressure. Ooh, that's a 0. Okay. Now, if I wanted to test the proximal medial fibers of the RecFem, I'd test down here, wouldn't I? That make sense to everybody? If I wanted to test the distal medial fibers, I would test up here. Okay? Lateral, I'd have them turn this way and have them press up to the ceiling. Breath in and out, meet my pressure. It's a 0. Okay? And then, of course, this is distal lateral. Proximal lateral, and right up here is distal lateral. Okay? So you can get really specific. I want you to get really specific. We've just been kind of learning, right? But now, I want you to really, really, really get specific. Okay? So, you got nothing going on in that RecFem.
Yep.
Yep. So what did they find was the TL?
Some stuff in my neck.
Well, that clearly didn't do anything. Any scars or anything on this leg I need to know about?
No scars or anything like that. I've had some knee injuries on the left side, though.
You have? Medial or lateral?
I popped the kneecap loose.
You popped the kneecap loose? Well, that might do something.
Yeah.
Just a little thing like that.
Yeah.
Okay.
Oh, it's all back. It's good.
Got great quads, dude. All right. That's, so kneecaps are held in place by the muscles on the inside and the outside, right? So let me see what's going on here. Let's see what's going on out here. That interesting right there?
Yeah, a little interesting, yeah.
Kneecaps, when they pop, generally go laterally, not medially. Okay? All right, so I'm just going to touch right here. Shall we see what your RecFem does now?
Sounds good.
All right. I'm going to hold here. Breath in and out. Meet my pressure. Was that easier?
Yeah.
Turn this way. Meet my pressure. Well, not that way. How about this way? Meet my pressure. So for the middle and the outside, this works great. I mean, for the middle fibers and the lateral fibers. Now, the medial fibers, I'm going to probably pick on something on the inside here. So tell me what it feels like on the inside.
There and there.
That's a good spot. All right. Yeah, that's it right there. I could feel him organizing as soon as he held his leg up, right?
Yeah.
The others, if I did it out here with this one, it's a drop.
Oh, yeah.
Yeah. If I touch here, he organizes immediately. Okay? So when the hips go, especially the rec fem, what's the next joint down? The knee. Is the knee ever the cause of anything? It's almost always, unless you get taken out in a soccer game or a football game or something like that. But under normal circumstances, the knee is at the mercy of the hip and the ankle, right? So in this case, his was at the mercy of his hip. Okay? So weak hip flexors, etc., will cause knee problems. So whenever somebody comes in with a knee problem, first thing you want to look at, rec fem. Can they control their rec fem? And in Graham's case, the answer was no. He can't control his rec fem. Okay? So he was having, extra tension in his IT band down here, right, which pulls the kneecap laterally, and he was having extra tension in his adductor magnus, which pulls his kneecap medially, right? And then those two got into a battle. We'll get into that in a minute. All right. So those two, this one needs to be released to activate the outside. This one needs to be released to activate the inside, and that's normally how it works. Inside goes the inside of the knee, outside to the outside. Okay. So just follow those lines. Everybody follow that? Okay. So you saw OPCD and rotating the hip joint to expose medial, middle, and lateral fibers. Everybody got that? Okay? Good. All right. Thank you, Graham.
Thank you.
Well, actually, stay right there. Since you're screwed up enough to be good for this one, too.
Sounds good.
Yeah, all right. So let's look at hip adductors and abductors. Add and add. Okay? And this will finish up our hip muscles. We've covered everything else. So, adduction, abduction, right? So there are 5 adductors, okay? In this position is the pectineus, adductor brevis, adductor longus, adductor magnus, and gracilis. 5 adductors.
Please leave it my going.
You're not supposed to know that. Somebody told you.
No, your material.
Huh?
I did the homework. It's on the module, the anatomy module.
I said that? Okay, whatever. Okay, so those of you that don't know this, to remember this, there's a mnemonic device that I like to use for this one. Mnemonic devices that have sexual connotations work way better than regular ones. They've done studies on this. I'm not making this up. They actually work way better. Way better. Okay, so with the foot turned out like this, okay, and I stabilize the other leg, I'm going to have him pull this leg towards the other. That's pectineus. Here's brevis, okay. Here's longus, magnus I'll turn in, and gracilis I'll turn in even more. Okay, so to remember those, say after me. Please, baby, love, my groin. I know you're scarred for life. All right, but you'll never forget your adductors after that. Huh? You got it.
Write it down.
You know your adductors. Okay, so those are the 5 adductors, and we have 3 abductors. We have the gluteus medius, gluteus minimus, and we have the tensor fasciolata, which is also a hip flexor. And gluteus medius is also a hip extensor. They got different fibers. They do different things. That's why one name doesn't suit all purposes, okay? But don't blame me. I wasn't there when they named this shit, right? I would have had way more fun with this. Way more fun. Very uncreative naming of these things, right? I object. All right, so you've already seen this test. This is tensor fasciolatum, meet my pressure. He's got nothing. And here is mid and mid. And press out and meet my pressure. He's not got too much there either. Now, that's okay to do supine, but I actually prefer side-lying hip abduction testing there. So lie on yourself. Bend your bottom knee. Can you see okay?
Yeah.
All right. So lift this leg up. Breath in and out. Meet my pressure. Now, come a little bit forward. This is gluteus minimus. So this goes just like anatomy. Goes from posterior to anterior. And this is TFL, and forget that. All right. So if he fails the first one, which was gluteus medius, the rest are shot. They can't do it. Okay? More often than not, the TFL is the weakest of the three abductors. Okay? So his abductors aren't working, but his adductors are actually, to start with, they seemed okay, right?
Yeah, they're okay.
They're okay. Yeah. So lie on your back. Okay. So you have any adductor pain, groin pain? Does that ever happen?
Yeah.
Where?
Left side. Usually it's high more in the insertion or mid.
Okay. Since this is our first date, I'm going to let you TL yourself. All right? There we go. All right. Breath in and out, and meet my pressure. That's better. Breath in and out, meet my pressure. Okay. So we clearly have a relationship between adductor and abductor. Now I have to fire up the adductor because it's directional testing. Good. And then I'm going to retest here. Breath in and out. Meet my pressure. No, it's still weak. Okay. So what's facilitated? Adductors facilitate. Abductors are inhibited. Correct. So facilitated adductor. Okay. Facilitated adductors can cause some serious problems. Yes?
Yes.
Okay. Groin pulls and groin strains from playing sports, not fun. Can be a very debilitating injury. Okay. You ever have one of those?
Mm-hmm.
Yeah.
Oh, yeah.
I would bet you would.
Yep.
Yeah. Okay. So he needs to release his adductors and activate these guys here. Now, what kind of homework would I give for this? Okay. So he could just do some manual work on his adductor. You know, putting a ball in there for a guy. Not a good idea. Not a good idea. Stop. Make you too nervous. All right? Lie on your side here. So after you release the adductor manually, then he would do then some abduction leg lifts like that. Okay? Now make sure that you're only feeling it here and not in your adductor. If your adductor starts to kick in, you shut it down. Okay?
Yep.
Got it?
Got it.
All right. So if it's not 20, 3 sets of 20, it's only 3 sets of 5. That's what you do.
Sounds good.
As soon as you lose control, you go over your neural edge, you shut it down.
Cool.
Got it?
Sounds good. Thank you.
All right. You're welcome. Okay. Hop off the table. All right. Now, the last thing we're going to look at before we go back to the tables, the deep six. The deep six, the rotator cuff of the hip, the piriformis, the obturators, etc. Okay? These are just slightly important. Sciatic nerve, hip joints, all kinds of things.
Pelvic floor then as well?
The obturator internus is part of the pelvic floor, that's correct. Yeah. But we're not talking about the pelvic floor. Yeah. Level 3. Hold that P for right now, okay?
If I could.
If you could, you would. Okay. That'd be a long time. Then you'd have a hell of a pelvic floor, right? Yeah. So those deep six muscles are the rotator cuff of the hip joint. We normally think of rotator cuff is up in our shoulders, but the hip has a rotator cuff as well, and it's formed by those 6 muscles. Now we only have 4 tests because the gemellus superior and the gemellus inferior are synergists for the obturators, so we don't distinguish those in our tests. Okay? We're going to have 4, as I will show you. Now, what is the clinical significance of these muscles other than sciatica? So, let's say your glute stops firing, and then your piriformis takes over. Okay? So that's a local muscle compensating for a global muscle. That's not a fair fight, is it? You're overburdening the little guy goes crazy, contracts, and then pinches the sciatic nerve. Now, the obturators can do that, and the quadratus femoris can all do that. This sciatic nerve is just going right along the path there, okay? So that's a leading cause. They call it piriformis syndrome, but it can be in the obturators as well. It can also happen from piriformis, et cetera, compensating for quads or hip flexors. Test don't guess, right? We'll show you some examples. And also, a common hip joint problem is lack of ability to cross your legs. Where one knee sticks up in the air, you can't really cross your legs, your knee doesn't drop down. Anybody have anything like that?
Mm-hmm.
Yes, you have, Micah? All right. Who else? Was Micah the only one? You had it too? Micah, come on over. Which side?
Left.
All right, good. Head up there. This is a great way to show testing for the deep six. Okay? So this is called a favor. I'm doing you a favor.
Okay.
Okay. So that's, favor stands for flexion, abduction, external rotation. Okay? It's not Fabe. It was named after Dr. Fabe. No. It's a favor. Okay. And then let's compare it to that one. No, it's not terrible, but it ain't what the other one is. Look at what he does there, and then show us the other one. So you see he has more range of motion on that side than this side. Okay? So the muscles that suspend the femur in the acetabulum are the obturator internus and obturator externus. They form the posterior hip joint capsule. In the front, the hip joint capsule is formed by the adductors and the crossing over the iliopsoas. Okay? So we want to look at obturator function here and see what we can find out. Right? Bend your knee. I like to do this test too. This is, how's this through here?
Does not feel good.
Crossing the midline.
Do you have a torn labrum?
I hope not.
Good. You weren't told that you do. No, I'm not telling you that you do.
Good.
So that test is what we call the pectineal pinch. That means the pectineus is overcontracted. There's actually, you can look that up, pectineal pinch. So it's when the pectineus is overworking for something. It can mimic a labral tear. Okay? So don't assume a labral tear is a labral tear. Anyway, why in God's name would you want to have your labrum repaired anyway? It doesn't work. Okay? The statistics on labral repairs are dreadful. Dreadful. I hope they stop doing it. It just doesn't work. Conservative physical therapy is way more effective than going in and tearing up somebody's joint. Okay? All right. So you seem to have a pectineal pinch.
Yeah, it pops too.
And it pops. You have a popping hip too?
Yep.
That's your psoas.
Yep.
So you have a clunky psoas and a pectineal pinch?
Mm-hmm.
Woof! You got clunky psoas pectineal pinch syndrome. You got clips.
Not yet.
Not yet?
No.
You're not getting clipped yet?
No, you gotta get kids first.
Oh, that's true. That's true. That's true. All right. That's a good idea. Yeah. All right. We diverge. It's getting late. We're diverging here now. All right. So when you're testing these these are the external rotators of the hip, of course, as a group. Don't have the knee above 90 degrees. The knee has to be below 90 degrees. When the knee comes above 90 degrees, they switch to internal rotators. Therefore, we can't test them like we'd like to. So, knee less than 90. So, this right here, remember, watch the femur, not the tibia. Okay? The femur is doing what? External. Tibia is doing what? Internal. Don't pay attention to the tibia. So this is external rotator. Okay? This position here is the obturator internus. This is the externus. And this is the quadratus femoris. So I want to test those. Okay? So breath in and out. Meet my pressure here. Good. Meet my pressure here. Good. Meet my pressure here. And meet my pressure here. Good. So they're all testing strong in the clear. Okay? What does that tell us? Not much
Strong in the
yet.
clear.
It's just strong in the clear. Exactly. Let's see how they react with the glutes. Okay? Breath in and out, and meet my pressure. We got nothing. Okay? Touch your butt. A little more. Go push through the glute into a little deeper. Okay? Breath in and out, and meet my pressure. You're close. Go a little lower on your butt. Breath in and out, meet my pressure. And there it is right there. Okay? So roll on your side so they can see where you were touching. Okay? Show them. Right about in, out. Right about in here. Right about here, which is the back of his hip joint. So this is where the obturators live. Okay? The obturators form the back of the hip joint. Okay? So this is obturator land right here. So he TL'd his obturators and his glute turned back on. Okay? So that's relational compensation, right? We started with a strong clear, then we found a weak and clear, we TL'd. They have a relationship, so we're on to relational compensation. So now we just release the obturators. We don't have to go back and forth. Okay? How's that here, Micah?
That's great.
That's good. So if you want to rehab the hip joint, this is one of the most important things you can do. Figure out what the obturators are up to. Especially when somebody's stuck, with one knee pretty significantly higher than the other when they sit cross-legged. That's a jammed hip joint. And what's the precursor to a hip replacement? A jammed hip joint. And how many people have hip replacements nowadays? Way too many. Lots. Lots and lots and lots. It's the most common orthopedic surgery. It's very successful. They do a good job. But they wouldn't have to do it if your hip joint was working properly, right?
I have a question you're not going to like.
I'm so happy about that.
Could you also do contract relax to release it?
Of course, you can do whatever the hell you want.
Okay, so it doesn't have to be a manual technique. It can also be...
Whatever you like.
Okay.
Yeah, peanut.
I don't care how you do it. I'm not here
Well, I
to
was
teach.
always thinking you could just put pressure on it in a certain way, but you could also relax.
Whatever you like.
Okay. All
Turn
right.
on your back.
Use fascia blaster.
But for you,
Only for the
for you, of course, the anal attack.
Right. They all look like an anal attachment.
Breath in and out, meet my pressure. That's way better. Okay? Now let's see if it drops out better now.
It's a little bit.
Feeling a little better?
A little bit.
A little tight in the groin.
Still
right?
tight, yeah.
Yeah. We're not done.
Right.
No.
Good.
Okay. I've only treated the posterior hip joint capsule, so you got to see that process, right? Okay. Now, we have the anterior hip joint capsule. I'm concerned about the pectineus, okay? So let me test the pectineus first. Breath in and out, and meet my pressure here. Now let's test the psoas. Breath in and out, and meet my movement. That didn't work too well. No. You know where the pectineus is in the front? Go ahead and touch it. right below your pubic bone there on the lateral edge. Yeah. Lock your knee. Breath in and out. Meet my pressure. Yep, that worked. So now he needs to have his pectineus released. That's a good line for a first date. What do you think? Yeah?
Use psoas.
Right.
Yeah.
So you have to sign a release first.
You have to sign it. Okay. Now remember, he also said he has a clunky psoas, right? So you know what the clunky psoas is when you straighten your leg out and you hear that kind of deep pop inside? A lot of people freak out and think it's coming from their lumbar spines. My God, if that was your lumbar spine, you'd go to the hospital, all right? It's a weak tight psoas. The tendon of the psoas is actually popping up over the ilium, okay? So in that case, would you want to stretch your psoas?
Super, I think that.
Would you want to stretch that psoas? Yes or no? No. Thank you.
Yeah, mine is worse.
Yours pops?
Yeah,
She just did it.
Oh,
Both
yeah.
sides.
I didn't hear it.
Are you
So, you know, the common treatment for clunky psoas is to stretch the psoas. Guess what that does to the psoas? It makes it weaker. And then it gets tighter to protect itself. You're like making things worse instead of better. Why are people teaching that? I don't get it. But they are.
It's on Instagram.
Of course, everybody wants free advice from me on this here. Right? I have a crystal ball. You guys didn't know that, right? I can dispense accurate advice without seeing people. Absolutely. All right. Breath in and out. Meet my pressure.
A little better, yeah.
I'll say.
Yeah.
All right. Here we go.
Yeah.
That was good.
Yeah.
And so your pectineus. So this, I want you to remember this relationship. Write it down. Think about it. Pectineus to psoas. It's super important for the hip joint. Obturators to glutes. Hip joint. Pectineus to psoas. That's your go-to one to correct hip joint dysfunction. And then if you're a chiropractor, PT, you can do a long axis distraction and pop it out after that. It's great. Okay? But since most of you are not PTs and chiros, we won't do that. But those of you who know what I'm talking about, go ahead and knock yourself out and do it. All right? It's great. Okay. So you got the idea, everybody?
I have a question. If you could lay on your side again.
Go ahead.
So you had your finger on the obturator. Where would the piriformis be?
Oh, you want me to show you? Okay. So remember, piriformis is right along the edge of the sacrum, and it goes to the trochanter. So this is piriformis here. Obturator's here. Obturator here. Quadratus femoris here.
Can you show that again, please?
Piriformis to the trochanter. Obturator to the internus to the trochanter. Obturator externus to the trochanter. Quadratus femoris to the trochanter. They all attach to the trochanter, right? But the obturators are right here, and if you feel the back of the head of the femur, you'll feel the obturator sitting on top of the back of the head of the femur. If they're too tight, they pull the femur up into the acetabulum and cause a hip joint jam. In the front, if the pectineus and the adductors are too tight, they'll pull the front of the femur up into the acetabulum and cause a hip joint jam. Oftentimes people have both. Sometimes one, but oftentimes both. Okay? Everybody got that? Good. Now, for homework, is let's say they have a hip joint jam. You give them, the releases and the activations. A great follow-up on this, get up on your elbows. Bend your right knee. Get on your elbows. Yeah, like that. Bend your right knee. Put your foot on the ground. Yeah. Okay. So you know those jump stretch bands? They come in 35-pound, 50-pound, right? the round loops of like a TheraBand, thicker? Okay. Wear a sneaker, wrap, secure the band to the sneaker, and the band's going to stick out that way, and you attach it to a door or to the dining room table leg or whatever you got, something that's immovable, okay? Then, with it like this, you're going to back away from me, and you see how that will distract it. See how that distracts the hip joint? So that's what I give people for homework to distract their hip joints. Okay? Everybody got that? It'll be on film anyway, so you'll see.
Pull my leg like that.
Yeah, no, it feels really good. It's good. All right, so, Michelle, shut it down. Paul used to run track, and we think he tore his biceps femoris. But if you get really close, I was pointing at you, Madame. Kelsey, get closer here so you can see. Okay? All right. So meet my pressure here. Pull your heel to your butt. Not too strong. He was showing me before he has a big bulge right here. How did you get it to work? How'd you get it? What'd you do?
I was doing 4x100 handoffs.
No, how'd you make it? Show us the bulge when you contract. Oh, there it is, there. All right. So there's a tear here. He tore his hamstring. Okay? All right. So I'm testing the hamstring. This is obviously the middle fibers. This is kind of a general functional test. It includes all of them. If I turn the foot out this way and go like that, I'm getting biceps femoris. If I turn in this way, I'm getting semimembranosus and semitendinosus. Okay? And of course, this is the open position, and this is the closed position. Okay? So we'll do the kind of a belly of the muscle test here. Meet my pressure here, and you've got zip on the hamstring. Okay? And meet my pressure, nothing. And meet my pressure. Look at that. So his lateral hamstring is actually firing, and his medial hamstrings are not. So what happens when you sprint under heavy load and one set of hamstrings doesn't work and the other one has to work harder? You could tear your hamstring. Okay? So I'm going to go in here, near where the tear is here.
Oh, right there.
That'd be it right there. Okay? So now when he turns his foot in, go ahead, turn your foot in, meet my pressure here. And now we have an engaged medial hamstring. All right? So we'll do directional testing again, meet my pressure here. Still strong. This way. Weak. So which one's facilitated? Biceps femoris, where he tore it, right? So release here. Obviously gently. Good spot here?
Right there.
Right. And you could do a pin and stretch, right? I could hold it and extend the knee that
ART?
way. Huh? F-A-R-T. Fake ART. It's fake ART. What? I would never make a joke like that. Moi? No. Come on. This pin and stretch is really good for stuff like this. If you like to do contract, relax, or muscle energy technique, or whatever the hell it is you like to do, knock yourselves out. All right? All right. Breath in and out, meet my pressure. There you go. And now it's starting to come back, right? So your homework is what? Release here and do hamstring activation with your foot turned in. That make sense?
Yep.
All right. And then let's check his other side so you can see the difference, right? So we'll test his biceps femoris first. Meet my pressure here. Good. Turn your foot in and meet my pressure. No reaction on that side because you didn't tear this side up, right? So people always say to me, shouldn't I do exercises bilaterally? No. Not an NKT, you don't. It ain't broke, don't fix it. And if he's, the people then say to me, well, why can't I do squats for my hamstrings? Duh. Because your brain will use the path of least resistance and never will engage the medial hamstring, right? So if you overload an exercise and their motor control is not yet firm in their brain, they will use the path of least resistance, cheat it, and they'll never fix themselves. Everybody got that? So when you're rehabbing somebody, regress the exercise to the point where it actually works. Don't start with squats with a torn hamstring. That ain't going to work, I promise you. And if they have weak glutes, neurologically underactive glutes, and you give them a squat, they're not going to work. No way. Why would the brain do that? It's not going to. Okay? So keep all that in mind, okay? Those are questions people ask me all the time. Shouldn't exercise be bilateral? We're not exercising people, we're rehabbing, okay? Not bilateral. Good, thank you. So those are your hamstring tests, okay? Now, who's had knee surgery here? Raise your hand. Oh, we have some people. Who else? Who had that big scar on their knee? Who was that?
You want to see it?
That was Andrew. Was it Andrew who had the scar? Okay. Come on over here. Which knee? Okay. Head up here. Head up here. Unless you're having a cranial rectal inversion. What? I'm a meteorologist. What can I say? All right. Okay. Oh yeah, here it is. Oh. Here's a nice scar right here. Okay. What happened there?
I tore my ACL twice. So I've had 2 reconstructive knee surgeries. Also damaged my meniscus, my medial meniscus twice.
It goes along with the territory. And allograft or autograft?
First one was an allograft. Second one was a cadaver.
Allograft is a cadaver.
Oh.
What was the autograft? Where did they take it from?
Oh, they took it from my quad or my
patella tendon?
Yeah.
Ouch. Okay. So you guys know what an autograft and an allograft are? Yes? Auto means take it from their own body. Allo is from a cadaver. Okay? From the Latin, self and other. Okay. All right. Here we go. Hold your leg up. Now we're just going to test the quad in the clear. Okay? Breath in and out. Me and my pressure. Tim Burr. Okay? Think maybe I should touch the scar? All right. Breath in and out. Me and my pressure. Aha. Okay. So since your surgery, your quad's not been doing its job.
Yeah.
Probably before you ever injured your knee.
Yeah.
Your quad wasn't doing its job.
Yeah, it sucks.
How about this one here? Need my pressure. Yeah, that one works. This one doesn't. Okay. So now we have more scar work to do here. And we'll get to that. But what I wanted to show you was the popliteus. So the popliteus, as you know, is that little tiny muscle behind the knee, where they tell you in many different schools not to work on the back of the knee. Now, who made up that dumbass shit? I have no idea. But let's work on the back of the knee, shall we? Because it's very important. Not only does the popliteus has been known to contract at 300% in normal after knee surgery. 300% in normal. Do you know what important nerve runs through the popliteus? The tibial nerve. And if you see me post about this, I do frequently. Overcontraction of the popliteus impinges the tibial nerve. People end up with numb calves and bottom of the foot. That's the path of the tibial nerve. Or it goes to the peroneal, the common peroneal nerve, and ends up with numbness in the side of the leg and the top of the foot. So depending on the flavor. Tightness in the back of the knee is not good for nerves. Okay? I commonly get runners in who have tingling and numbness in both of their feet. on the bottoms of their feet, right? And they've been to the doctor, oh, you have an L4-5, you have an L5-S1. And then they go and have an MRI and there's nothing wrong with their back, right? And then the doctor says, well, you know, we should probably do an exploratory surgery on your lumbar spine. And you end up like Steve Kerr, right? Okay. So in that case, I just know that it's the popliteus and get in there, and sure enough, that's the end of that. No more tingling. Okay? So knowing anatomy is kind of helpful. Okay? But aside from that, let me put my hand on the back of the knee. Okay? Lock it straight. Breath in and out. Meet my pressure. That didn't work. Okay. So we'll try different parts of your popliteus. Right here. Meet my pressure. That definitely worked. Middle of the popliteus. Nope. And the tibia part here. No way. So it's really here on, well, excuse me, it's really here on the medial side of the popliteus where it joins the tibia. It goes from lateral femur to medial tibia. So right back here on his popliteus is not happy. And this is not far from the medial meniscus. Popliteus and medial meniscus have a nice relationship. Also to the ACL, medial popliteus. Okay? So there's some problem back here too, aside from the scar.
Yeah.
Okay. So now I have to test the popliteus because the quad was weak in the clear, right? That makes sense to everybody? So get very close so you can see this popliteus test. Okay. Those of you in the back there, you're not going to see anything. All right. So what does the popliteus do? It has two functions. One, medial rotation of the tibia, so it does that, okay? And it also flexes the knee the first 10 to 15 degrees. So it flexes the knee and it rotates the tibia medially. It does those two things, okay? So why don't we combine those two things into one test? We get two tests in one. You guys too young for that one? No. Any of you older people get that one?
I was busy.
Two tests in one. Two tests in one. Remember? The chewing gum.
Double mint gum?
Double mint gum. Double mint gum. Thank you.
And just ages last.
All right. Meet my pressure here with your
He has a
foot.
new joke, Dave.
Yeah. Can't forget that joke. Forget that joke. All right,
You
bend your
said
knee.
2 mints in one? It was 2 mints in one.
Yeah.
Because it's double mint.
It's double pleasure.
Yeah, double your pleasure, double
But
your
not 2
fun.
tests in one. That's what I get it. Oh, my God, I get it. And I'm old. So.
Yes, I substituted the word mint with test.
That was a break.
Okay, all right.
No one else got it.
You're killing me here, Ollie. All right, press your foot against my forearm here. Immediately rotate your tibia. Bend your knee slightly. Pull your heel to your butt. So there's the popliteus test. Resisted medial rotation with the forearm and resisted flexion of the knee at about 10-15 degrees. Okay?
Can you break up the two?
You could, but why?
Well, what if one part's dysfunctional and the other's fine? Right? Then there's 2 parts, one test.
I'm wanting to see neurologically what the popliteus will do.
Okay.
Okay, so if I just test it like this, bend your knee, and I just ask it to do the first 10 to 15 degrees, it also blends in hamstring.
Okay. Oh.
If I just ask it to do this by itself, it blends in internal rotators of the hip and all that stuff. So I'm trying to take as much noise out of the equation as possible. Got it?
Got it.
Good question.
Thank you.
Thank you. All right, let's do it again. So for the left leg, you use your left hand. That easy to remember? All right. Turn your foot in, meet my pressure against my forearm, slightly bend your knee, and pull your heel to your butt. Okay, so that fired up the popliteus.
Are you
Let's see how the
holding on to
quad.
the popliteus? I'm sorry, are you holding on to the popliteus?
No,
or
I'm
you-
not.
Okay.
No, I just wanted
That's
to
some
bend.
flexion.
I might just put my hand over there to get the knee bent a little bit, but then I take it away. Yeah. So breath in and out, beat my pressure. Okay. So he has no quad after I fire the popliteus. Okay? So let's see if I TL the popliteus, which I did before, it should make the quad stronger. Okay? So that was like right there, right?
Yeah.
All right. Breath in and out, beat my pressure. Okay? So we know there's a relationship. Well, the medial portion of the popliteus is facilitated for the quad. And this is a common relationship, popliteus to quad, especially after knee injuries. Quads tend to go offline. So then you want to release the popliteus, so I like doing it this way, knee bend, rest in this position. Okay. This is right here on the medial portion, medial superior portion of his tibia. He's enjoying that. Is that fun? And again, don't forget the relationship to the tibial and peroneal nerves from the back of the knee. Okay? It can be scary for people when the bottoms of the feet start to go numb, right? It's very scary because everybody starts to think they have a back problem. And most of the time it's not a back problem, it's a knee problem. Something else that people actually know how their bodies work, right? That would pretty much be the end of the pharmaceutical industry. But they don't have that. Better to scare people, right? Can control people better if you scare them. Do I sound like an old hippie?
A little bit.
Yeah, a little bit. Yeah. So breath in and out, and mute my pressure. Beautiful.
Awesome.
Popliteus to quad. I don't want you to forget that relationship. Sometimes it goes to the glute too. You can have popliteus to glute, but the most common one I see is popliteus to quad. Okay? Functional opposites, right? Knee flexion, knee extension, et cetera, right? That make sense? Okay. So now, before we go home, you can shut it down, Michelle.
Oh, okay.
Little tendonitis in this ankle, huh? Okay. So, let's look at the muscle test for the lower leg. All right? Here we go. If I put my hand right here and she plantar flexes against my hand, go ahead. That's the gastrocnemius. It crosses the knee and the ankle. It's a two-jointed muscle. Two-jointed muscles are the ones you really want to pay attention to. They have the most problems. One-jointed muscles, not so much. Two-jointed muscles, pay attention to. Okay? Bend the knee. Same test basically, but with the knee bent. That's the soleus. Why? Because the soleus doesn't cross the knee. Okay? So that's gastroc and soleus. And there's one more plantar flexor I want to show you. And that's the tibialis anterior. So you turn the foot in like this, and you put your hand on the inside edge here. So the tibialis anterior. Tibialis posterior, Tibialis posterior runs from the lateral tibia, and it goes down on the diagonal like this in the back, and it crosses under here, and then it goes to here, and helps form part of the medial arch. It's part of our stirrup system in our foot that allows us to pronate and supinate. So I want you to plantar flex, and I want you to supinate at the same time. So tibialis posterior does plantar flexion and supination. Everybody got that? Okay, go ahead and meet my pressure, and that's tibialis posterior. Tibialis posterior does plantar flexion with supination. You got to remember that. Got to remember what does supination and what does pronation. Right? Okay, now, I'm sorry, there's one more plantar flexor that I forgot. And that's the peroneus longus and peroneus brevis test. So those guys do pronation, but they also do plantar flexion with pronation. So plantar flex, and then pronate, and then meet my pressure here, and that's the tibialis. I'll get my names right eventually. Peroneus longus and brevis. And they start up here at the tib-fib joint and cross and form support for the lateral ankle, and then come under here and kind of connect with the tibialis posterior to form the stirrup of the foot. Okay? All right, so those are all the muscles, major muscles of plantar flexion. We do have the toe flexors, right? We have flexor hallucis, meet my pressure here, and flexor digitorum. They also contribute to plantar flexion. Okay? And they're important when it comes to plantar fasciitis. Very. Because they start out here on the lateral lower third of the tibia, and then they cross over here into the tarsal tunnel here, the Tom, Dick, and Harry muscles, right? Tibialis, posterior, flexor digitorum, and flexor hallucis longus. Those are the Tom, Dick, and Harry muscles. You guys learned that in school, Tom, Dick, and Harry? Yeah, that's what they call them. So when people have tarsal tunnel syndrome, one of those muscles is not too happy. Remember that, okay? It's not that common of a syndrome like carpal tunnel syndrome, but I see it often enough. You should be familiar with it. But anyway, the toe flexors, when they really get going, they get really tight, they can contribute to plantar fasciitis. So in the warm weather, when people are wearing sandals, and they, flip-flops, I should say, not sandals. I don't wear flip-flops. When you wear flip-flops, your toes grip to keep the flip-flops on, right? That makes your toe flexors start to over-contract. So everybody stand up. Not you. Well, you could hardly stand. Well, no wonder your feet are messed up. Look at your socks. Grip your toes really hard. Which direction does that pull your body in? Forward or backward? Forward. So if you keep coming forward, what does your head have to do to keep you from falling?
Extend.
So my name for flip-flops is neck fuckers. You see a lot of neck problems in the summertime from flip-flops. You really do. Yeah. I have, that's my brand. NEKFQRS.
Nice.
That's my brand. Yeah. Trademark. TM. Yeah. All right. You okay, Holly? Holly's losing it. All right. All right. Now we have the toe extensors. Of course, we have the extensor hallucis and the extensor digitorum. Okay. Then we have, these are going to also contribute to dorsiflexion, right? The big muscle of dorsiflexion, of course, is this one right here, the tibialis anterior. It does dorsiflexion with supination. So dorsiflex, supinate, and you have that big muscle right here, tibialis anterior. And then we have the little tiny dorsiflexor, the peroneus tertius. This one right here, it pronates and dorsiflexes at the same time. Little tiny guy, but it can have some problems. Don't you love that name, peroneus tertius? I always want to go, all hail peroneus tertius. Wasn't he the one that burned Rome down? No. That's Donald Trump. Okay, all right. So, I had to throw one in there. All right.
It's not even 9:30, okay.
I wake up this way. All right. So those are all the major muscles of the lower leg. All right. They're very simple. You just have to think what's plantar flexing, what's dorsiflexing, what's supinating, and what's pronating. That's all you have to think about, okay? Once you get that, once you associate the muscles with the movements, then you know what to do with it, right? Knowing names doesn't do you any good whatsoever. Knowing some of the things that actually contribute to the movement patterns, then you got something, right? That's useful knowledge, okay? So those are all the tests, but then how do we put it into action, okay? And now I'm going to show you how to put it into action. So stand up, and let's clear this table up for a second, all right? Somebody grab the other end of it, please. Move, all the way over there. Okay, good. All right, now, no, you stand over here. Everybody come up. Where's the best for you, Michelle, for her to stand?
There's fine.
Right here's fine. I want everybody over here so you can see the front of something. And don't block the camera. Okay? Come on, guys. You guys aren't going to see a damn thing back there. Come on. Get in front here so you can see her feet. Micah, for God's sake, get over here. Sit down over here, Micah. Come on. All right. Rodrigo, seriously. Get your ass over here. Come on. All right. Okay. All right. Now, feet together, excuse me. Put your feet together. When you're doing a single leg stance assessment, feet have to be together to the best of their ability, depending on their weight and all that sort of stuff, okay? So I'm going to have her bring her left knee up like this, and she's going to stand on her right foot, and I want you to watch what the foot does when she brings her knee up to her waist, okay? Bring your knee up 90 degrees, look straight ahead. So that's called pronation. Did everybody see that? Okay. Put your foot down. Now, lift your right foot up. And that's called supination. So, she's pronating on the right and supinating on the left. Which way would she fall? To the left or to the right? Say it out loud. Which way is she going to fall? She's going to fall to the left. That's correct. So if I did a perturbation test on her, she would likely fall to the left. So let me show you that. You can double check what you see. Put your feet shoulder width apart. I think your shoulder's a little wider than that. A little bit more. There you go. You're not giving yourself enough credit for your shoulders. All right, there you go. All right. So I'm going to push her sideways, left and right. And we're going to see where her balance is at. So I think from observing this test that she's going to fall more easily to the left, but I'm going to start over here and push her to the right and see if she's stable. Okay? So my hand goes here, and you notice that my other hand is here. Why is that? Because I've had people actually fall and had to grab them. Okay? So don't let that happen. All right? So meet my pressure. Don't anticipate. So if you push against me, we're not going to do the test. Once I push you, you push against me. Okay? So breathe in and out. I meet my pressure here. And she's rock solid. Now, do the same thing over here. Meet my pressure here. I think she's falling to the left. So if she's constantly falling to the left, her body has to compensate for that problem, doesn't it? Every step she takes, every move she makes. Wow, that sounds really good. I have to do something with that. All right. Yes? Okay. All right. So she's falling to the left. So you have in your notes how to look at pronation and supination. There are actually algorithms in the notes that we sent you in the email. So you should have up on your iPads or printed out. But I'm going to show it to you right now. But you have it in your notes. All right? So now, let's bring the table back. I'm going to grab the other end. Okay? That good, Michelle?
Perfect.
All right. Put your feet down there. All right, so this foot is pronating, and this is supinating. Correct. Now, there are two different algorithms for pronation and supination. So think about it. Everybody stand up, and let's feel it together, okay? Put your feet shoulder width apart, okay? Now, lean to the left. Well, actually, just pronate your right foot. Just pronate. Actually, pronate both your feet. That'll be better. Where do you feel that? The inside of your knees, the inside of your thighs. What do you feel out here in your abductors? Nothing. Now, supinate both your feet. You feel it on the outside of your knees, and you feel it in your abductors, right? So when you supinate, you're activating the outside line. When you pronate, you're activating the inside line. Does that make sense to everybody? That's what this testing is based on, okay? So everybody sit down. Okay. So I know that she's pronating here, okay? Can you see okay, Michelle? All right. I know she's pronating here, so let's test pronation. Let's fire a pronation and see what happens here. Actually, I'll start differently. Let's test her hip abductors, because I said when you pronate, abductors really aren't firing. Okay, so let's test her abductors in the clear. So hold your leg up like this. Take a breath in and out, and meet my pressure. How did that feel?
There was nothing there.
Yeah. Okay. Now, let's TL the peroneals. Okay? Some of you call this the fibularis longus. Don't ever say that in my class. All right? It's like dirty language. No. Who learned fibularis longus? Raise your hand. Wash your mouth out. Tell me how this is.
That's tender.
Right up here?
Oh, yeah.
Yeah. All right. So I'm at the proximal end of the peroneals. Okay? I'm going to TL here. She's going to turn her foot, breath in and out, meet my pressure. Tell them how that felt.
Much better.
Okay. Now, we know there's a relationship, so now I have to test the peroneals, right? And then retest the TFL. So, meet my pressure here. Push down and out. Okay. Down and out. Good. Okay. Retest the TFL. Meet my pressure. And it still stays weak. So, who's facilitated? Peroneals are facilitated, and the TFL is inhibited, which is what we would expect, right? So the algorithms I gave you are 99.99% accurate. So don't bother with directional testing, just go for it. Okay? You'll get really good results with those algorithms. All right. Once in a while you won't, and then you recalibrate. All right? So right there, you enjoying that?
In a very special way.
Fun, huh? Maybe coming to class worthwhile. Okay, a little bit of release here. Breath in and out, make my breath. That felt better, right? Mm-hmm. Okay. Now, on this side, we have supination, too much supination. And with supination, you're going to activate the outside line, so we would expect the inside line to be weak, right? So let's test medial rec fem and psoas and see what they do, okay? I meet my pressure. I don't think I'm going to even bother with the psoas, because if that test is weak, the psoas is going to drop right out of the sky, okay? That did not work.
It's not.
That did not work. All right, so we have two supinators, two major supinators, tibialis anterior and tibialis posterior. So let's have some fun with active therapy localization, shall we? You ready for this? You'll like this part. All right. So if I wanted to do active TL for the tibialis anterior, I would have her dorsiflex and supinate, right? Is that correct?
Correct. Correct.
Now let's see what effect it has on this muscle. Not a whole lot, right? if I wanted to actively TL the tibialis posterior, I'd have her plantar flex and supinate. And there you, now we know that we have to treat the tibialis posterior. Did you like that little differential diagnosis? I thought you might like that. Okay. I enjoy saying that, by the way. Differential diagnosis, for some reason, that just turns me on. Whatever. The alliteration of it, it's cool. All right. So, tibialis posterior, remember I said started way up here, lateral tib-fib area, and then it works its way through the heads of the gastroc down medially. Most people tell me they'd rather have a gum surgery or an IRS audit rather than this, all right? But you choose, whatever you like.
You know this will end sooner than either of those things, so.
You hope.
Oh.
Yeah, you got this one pretty ratcheted up.
Yep.
Getting a little better. Now we're going to retest this and challenge it, okay? So the challenge is to put it in a position where the tibialis posterior cannot work. So that would be the opposite motion, right? Dorsiflexion with pronation. Does that make sense? Okay, breath in and out, meet my pressure. And there's the lock. Okay, now stand up. And put your feet together and show everybody now how you pronate and supinate. All right, so on your, let me give you the instructions first. When you bring your left knee up, I want you to focus on using that muscle right there. So touch it. Touch your abductor, tighten it, bring your left knee up to your waist. There you go. You like that change? That's cool, huh? Yeah. All right. And now concentrate on your inside of your thigh and bring your right knee up. And now put your feet shoulder width apart. Okay? And I'm going to push you to the left and meet my pressure here. Woo. How'd that feel? Solid.
Totally solid.
Okay. Now, I could have just sold her a $500 pair of orthotics, or I could have done that in 5 minutes. Which one do you think you'd be happy with?
Yeah.
This one. Yeah. Holly.
So I'm not directly
You can
in front
stop
of,
it.
Yeah, please.
When you're testing the neck muscles, it's so important that you test lightly. You're going to ask the neck flexors to work against gravity. Please test lightly. You press too hard, you can hurt somebody. Okay? That's why you've tested enough now lightly that it's important that you really do concentrate on the neck lightly. Okay? Everybody got that? Okay. And give your partners feedback if they're pressing too hard on you, okay? If you don't tell them, they're not going to learn. All right? Okay. So let's go, and you guys do this with me. Put your hands behind your head. Bring your heads forward towards your chin towards your chest, and press back here and meet my pressure. Those are your lower cervicals, upper thoracic. Head in this position, press back. That's your mid-cervical extensors, and chin up and press down. Those are your upper cervicals and suboccipitals. Okay? And in this position, press up. We have neck flexors, which aren't working. We have her left SCM, not working. We have her right SCM, definitely not working. Okay? Tuck your chin, and I'm going to try and bring your chin up. That's her longest colli, also not working. Then we have her, well, let's do it for the camera here first. We have the anterior scalene right here at the eyebrow, medial eyebrow. not working. We have the middle scalene at the lateral eyebrow, not working. Anterior scalene here. Middle scalene here. She's 0 for on the neck flexors, all right? No, this is not uncommon after a whiplash. How long ago?
10 years ago.
10 years. So she's been holding her head up now for the last 10 years with no functional neck flexion. That's a long time. So how do you think her neck extensors must feel?
Ouchie.
Ouchie. Okay? So let me go back here. Now remember, this is weak in the clear, so we have to do directional testing, right? So I'm going to poke around here on her neck extensors. Right here on her right, she has a Frankenstein bolt. Okay. We have a right C5 Frankenstein bolt, and we have a left C4 Frankenstein bolt as well. Okay? We have 2 Frankenstein bolts. I'm going to TL each one of those. So I got 2 TLs. I'm double TLing here. Okay? 2. I tried that yesterday.
Still isn't.
All right. So here we go. We're going to redo all the tests and see what happens. Okay? Breath in and out. Meet my pressure. Tell them what that felt like. Uh-huh. And meet my pressure. And how was that?
Stronger.
And here. Tuck your chin. Good. Meet my pressure here. Meet my pressure here. 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 And so we went 1, 2, 3, 4, 5, 6, 7, 8 tests. So she was 8 for 8 on that one. So these 2 guys right here, C4, C5, the extensors around them, are compensating for 8 neck flexion functions. How pissed off do you think those are?
Super.
Super pissed off. Okay. So if we work on the neck extensors and we don't make any corrections to the neck flexors, how long will that change last? Till they stand up. Once they're in gravity again, goodbye neck flexors, right? Hello neck extensors. The old brain will always go to the path of least resistance, right? Okay. So let's do a little release here. Right C5. So if you're a chiropractor or a physical therapist or an osteopath, you know how to do manipulation on this segment right here, that you would do at the end of all the rebalancing. And it would go like butter. Okay. Not too happy there, huh? That's a little too long to have this, don't you think?
Yeah.
So you're going to have to do your homework, huh? Just to get me to stop doing this, you're saying yes, of course. Why not? You do a little here. I feel great too.
It was worse that side.
It's even worse.
Mm-hmm.
See, if you were Jewish and Italian, you'd be complaining right now. But you're English. So, you know, she's cool. That's what it's called, you know? Right? You give this to me, I'm not talking. All right. Good. And we'll give it a whirl here again. Meet my pressure. Wonderful. Tuck your chin. Meet my pressure. SCM. Great. SCM. Wonderful. That was really weak before. Anterior scaling. Middle scaling. Anterior scaling. Middle scaling. Wow. That's cool, huh?
Thank you.
You're welcome. All right, Michelle, you can stop. Good. So Fran has a C-section. Huh?
I have
2.
2 scars. I have an appendectomy
Yes.
and a cesarean.
Okay, when was the last C-section?
2000,
And when was the first one?
1974.
First C was in 70?
No, the appendectomy.
Was in 74 and the C was in 2000. Okay. So she has a history. Now, with scars, it doesn't matter how old they are, they still are active in your motor control system. The fascia is the skeleton of the sensory nerves. Did everybody hear that? So when you cut through fascia, you're messing with sensory nerves. And when you mess with sensory nerves, you screw up motor control. And here we are. Okay? So, very often, C-sections. I don't know any men that have had C-sections, but the women who have had C-sections, I had to state that to be politically correct, of course. The women who have had C-sections often report having lower back pain. Okay? That's the typical thing that we find. All right? You have that, Frank?
Yes.
Okay. All right. So if your abs are cut and the abdominal fascia is disturbed, the brain's ability to send a clear neural pathway message, whatever you want to call it, to the abs is compromised, the brain will compensate to stabilize the core area. Does that make sense to everybody? And there is a wonderful article in the files section of the NKT Scholars page about scars and their effect on motor control. Okay? So let's give it a whirl here. Okay? So first test, this is our functional abdominal test. All right? Do not put the knees at 90 degrees. That involves hip flexors. Lower it down, drop the heels a little bit. Now you're getting more of a ab test, quote unquote, right? So, breathe in, breathe out, and meet my pressure here. Down she goes. All right? Now, that's a weak in the clear test. If we're relating it to scars, directional testing does not apply. Scars, for your purposes right now, are always facilitated. So if it's related to the scar, the C-section scar is facilitated. Okay? So put your hands and try and cover up as much of that C-section as you can. Okay? Now, breathe in, breathe out, meet my pressure. Aha. So the TL made it stronger. Clearly there's a relationship. But we know that scars are facilitated. Therefore, that C-section scar, or a portion of it, is facilitated and the abs are inhibited. Correct. Okay. Now, we'll start with your right hand. Start at the far edge of the C-section scar. And we're going to go spot by spot, or area by area, pardon me, to see which area of the scar is the most neurologically active. Rather than treating the whole scar, we want to find a spot on the scar. Pardon me. Breath in and out, meet my pressure. So that's a no. Go a little bit towards, like halfway to midline, okay, and meet my pressure. No. Go to the midline, meet my pressure. Better. Go halfway to the left. No. All the way to the left. So which part won? The midline one, right? Okay, so we know that the midline has a relationship to the abs. But we want to know in which direction that area around that C-section scar is affecting the abs. So when they do a surgery, do they only work in parallel with the line of the scar? Yanking babies out and stuff like that? I don't think so. So they're pulling them out and it's creating vectors, and those vectors are what we call fascial distortions. So this work is not really scar work. It's not, like making the scar more beautiful. You can do that. That's not what we're talking about. We are working with the fascial distortions that have been created by the surgery. Everybody got that? Okay. Fascial distortions happen in vectors. They don't happen any other way. All right? So now Fran's going to take her hand on the scar, okay? And I'm going to have her pull it up towards her head and meet my pressure. Strong. Now pull it down towards your belly. Weak. So we know that the direction we want to work is up because it made the test stronger. Now move it up towards your right. Weak. Up towards your left. Weak. Straight up. Strong. So I take a scar and I move it in a star pattern. Up, down, side, side, diagonal, 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 diagonal. 8 different ways. You can also go in circles and all kinds of stuff, but let's not do that today, shall we? We'll save that for another time, all right? So it's a star pattern. Alan?
So the system you're showing us now is for scars because when we did it previously, they were touching where it hurt. Now we're touching where the scar is, which is not where it hurt on her.
Correct.
Okay, so this is different than what we did earlier.
Yes, it is. Same protocol, though. Just a different way to get there. Okay? Scars have their own. Okay. All right. So we know that if I pull up, where's the scar? Okay. Right here. If I pull up towards her head, I'm going to encounter some resistance because that's how we... So when I pull straight up, there is definitely a drag on that fascia. Okay? So what you're looking for when you're releasing is a drag on the fascia. In other words, it's resisting your pull. If it goes easily, that's not the vector. If it's hard to do it that way, that's the important part of the vector to release. Okay? So I'm going to put one hand below it to stabilize, and my right hand is pulling up towards her head to release that vector, to work on the fascial distortions involved with the scar. Everybody follow me? So scar work is really important, especially in the abdominal area. Holy moly. A lot of people suffer after C-section. So many women have lower back pain from C-sections, it's not even funny. And this is the cause. So if you're just treating the lower back, you're not getting at the cause. Okay? And you wait until that vector starts to soften up, so you'll feel less of a drag. And eventually it releases, and it kind of feels like hard taffy got soft. That's the best way to describe it. Some of you do fascial release therapy, right? Okay. All right, so that's softening up. And now take your hand away. Breath in, breath out. And there you go. Now the abs are functional. So what would her homework be? Release the scar on that vector, and then do some kind of ab work, right? Could be wall bugs, any kind of thing, right? Any questions about that? Good? Okay.
What if they have some other issue that's preventing them from using their abdominal muscles?
That's the scar. That's the primary cause. Scars are primary. Okay? Scars are primary. They're the closest to the limbic system that we know of. And that's right at the top. All right? Any other questions, Alan?
So just to be clear, so that is why, like in her case, you know she has a scar, so you're going to have her, you're going to check the scar, not check the low back. Right, okay.
Is there a rule of
If
thumb?
the abs start working, the lower back to the abs relationship is secondary.
Right, okay.
The primary is the scar. If we clear the primary, the secondary may clear up all by itself. It may not, in which case you test lower back to abs as well. Yeah.
What about the hip flexors? I mean,
That's secondary. All that's secondary.
Can we always assume the rule of thumb, scar tissue always the primary, always address scar
Always.
tissue first
Yes.
before you look at anything else?
Before you look at anything else.
Okay.
Correct. That's correct. And you can needle it, JD, whatever
Yeah.
you want to do, right? Okay. No, needling for scars is great. I'm not kidding.
Cupping on
Yeah.
mine. I
Yeah,
see such scars.
there are a multitude of ways to do this release. I'm just showing you how I do it. You can do it, some people use lasers, and people using all kinds of stuff with NKT, okay? Some of our docs over in Asia are doing something called perineural therapy, where they inject into the scar. There's all kinds of ways to do it. Okay, thanks, Frank.
Thank you.
All right. Who had the appendectomy? Where am I? That was you, right?
Yeah.
Ann, come on. Which side?
Right
Right side?
Yeah.
Isn't appendectomy always on the right side? That was a test. All right. Okay. You have to adjust the camera. Great. And do you have lower back pain? On the right?
Central.
Central.
Yeah.
Right.
Sometimes on the right.
Move up a little.
Can I ask you a question?
You
When
may.
a person have multiple scars,
That's level 3. Just pick the one that's gives the best TL.
okay, do you have to clear all the scar tissue before you test other things? Just pick the most,
Pick the most active one and clear that.
okay, thank
Yeah.
you.
Okay, so we know she has an appendectomy scar on the right, and she has right lower back pain. Now, some people have mirror organs. Some people's organs are flipped, and they actually can have an appendix on the left side, but let's not get into that. All right. Let's test your psoas because it's very much connected to the appendix, okay? If you look at the anatomy, psoas is right there, okay? So breath in, out, meet my pressure. Down she goes. Okay, touch your appendectomy scar. Breath in, out, meet my pressure. I'm a good guesser. Okay, so there's a relationship between her appendectomy scar and her psoas. All right? Weak psoas, tight lower back, that's secondary to the scar. Everybody got that? So if I just treat like QL to psoas like we did before, and the scar is still there, will anything have gotten fixed? No. Okay. All right. So now your job is to touch the appendectomy scar, and we're going to go in the star pattern, okay? So breathe in, out, and push it up. Nope. Breathe in, out, and push it down. That's better. Push it down to the left. Really good. Push it down to the right. Not so good. So let's pull it down to the left. Okay? Bend both knees. Okay? So I'm going to get on that. Is that it right there? Okay. I'm going to get right on there. And I'm going to push it down to the left, but I got to find a vector. Oh, there it is. Feel that? Yeah. Now you feel it. So I'm going down to the left where I get that drag in the fascia. Words are, everybody's got different words for this stuff, but you know more or less what I'm talking about. Okay? So I'm just going to keep moving that fascial distortion diagonally down to the left, and I'm going to wait for it to melt. Okay? So this kind of scar work is unique to NKT, as far as I know. Unless somebody stole it and out there claiming that they've invented it, I don't know. I haven't heard about that. It's a cool way to work on scars, really effective. Not scars, the stuff associated with scars. Right? There's a lot of people doing scar workshops. That's a superficial scar. We're not concerned about that. Okay? That's better. Okay, ready? Breath in, out, meet my pressure. Okay, so that's the primary relationship. We haven't dealt with the secondary. Okay?
How important is it, because you tested it, her left leg was still bent. Her right
I'm
leg was
protecting her
bent.
lower back.
But when it comes to retesting her psoas,
Yeah, I had her left leg bent.
okay.
The first time I did it.
I didn't? All right, do it without your breath in, out, meet
Take your
my,
hands off your body.
breath in, out. Oh, the peanut gallery's active. All right.
My question is, how much is all the other limbs important to how you test? Because the angle of the limb you're testing is important, but the hands or the leg or the knee or the bent?
Try and keep it at, whatever you start with, try and keep it as close to that as possible.
Okay.
It can change it.
It can, but not
Okay.
often. Yeah,
Gotcha.
not to worry.
Okay.
Yeah. Okay, so you've seen two examples now of scars to abdominal muscles, right? And we haven't dealt with the secondary compensation yet. We will. Okay, go ahead.
So in the release, you're just holding it at that vector until you feel the release. You're not doing anything, you're just holding it. Okay. Make sure
Fascia doesn't like when you do that.
Okay.
It prefers you to stretch it. Works much better that way. Okay? Any other questions about that? You'll see when you do it. You'll feel it. Not to worry. Okay, who had the scar? Mark. Where's Mark?
Right here.
Okay. Shoes off. Okay, so Mark, lie on your stomach. We'll do a little prone stuff here, okay? Tom, can you see these scars here? Go on over there. So what was done here, Mark?
Fusion.
At what level?
4, 5, and S1.
Oh, you have the classic. Okay. So he's got the classic here, okay? How long ago?
2.5 years.
Ooh.
How's that working out for you?
Great.
Good.
Feel better?
Well, I mean, I was miserable before, so.
Yeah.
Glad it worked.
I'm glad it worked too.
I'd say if I was 20% before, I'm 80% now.
Yeah.
That's good. That's good. So we have these nice scars here. But remember, and whoever did this did a very nice job.
It's very
by the way.
neat.
Very nice scars.
Yeah.
These superficial scars, not what we're interested, right? We're interested in the distortions around it. Okay, so when this gets operated on, I'm always curious about the function of the abs. Now, here's a prone test for the abs. Okay? So I'm going to go under his legs like this. Okay? And I'm going to lift up. Okay? Not too hard. Remember? Light pressure. So, breath in, breath out, and meet my pressure here. 0. Now put your hands on each scar. Touch your scars. Okay? Right there. That's perfect. Breathe in, out, meet my pressure. Tell them what the difference is.
100%.
Okay. Now, take your hand off the right scar and just leave it on the left. So now we're going to do a differential diagnosis. I love saying that. I love alliteration, you know. Differential diagnosis just tickles my fancy. What can I say? All right. So breath in, out, meet my pressure. Strong. Do the right one. Take your hand off the left. In, out, meet my pressure. Tell them what the difference is. Night and day.
Night and day.
So we know that something on the left is causing the problem, right? So, touch that left scar again. Okay, and let's move it up towards your head, and I'll retest and meet my pressure. Definitely not. Move it down and meet my pressure. Nope. Move it to the right and meet my pressure. Move it to the left. Meet my pressure. Now we're getting something. Now move it to the left and up and meet my pressure. Good. And down. Down to the left. Nothing. So the active part of that scar is up to the left. Correct. Okay? So Mark could be trying to strengthen his abs, but is it working or not? No.
Would you retest just straight over to the left again? Or can you just feel that?
I was feeling which one gave me the best neural lock. So straight over to the left was not as strong as up to the left.
And you just knew that because you were doing the testing.
Yes, correct. You wouldn't know from watching.
Exactly. That was my question.
Yeah.
Can a person have multiple strong?
Yeah.
Multiple vectors?
Yes.
That's level 3.
What's in level 2?
For your purposes right now, just find the one that gives you the best neural lock.
Okay,
Don't-
I think I know the answer.
Yeah.
Thank you.
Okay, well. All right. We can test scars against each other in level 3. We're not doing that right now.
Okay.
Okay?
Thank you.
Yeah. All right. So here we go up to the left.
Sorry. Does a person's neck position change?
It'd be better if you were in a headrest.
Okay.
But no, it won't change it, no.
Okay. Thank you.
Well,
Does the
that's a
testing
good.
always correlate to what you're actually feeling? Where the fascial pull is?
Yes.
Okay.
100%. Haven't had it fail ever.
But you test anyways.
Well, I
Yeah.
determined it first by testing.
Mm-hmm.
But then Lonnie was asking me if the vector didn't match up with the testing, and the answer is no. Yeah.
David, what?
The body doesn't lie.
Mm-hmm.
The brain does, but the body doesn't. Yeah. Yeah.
What type of pressure are you putting? The light to medium?
For release,
Yeah.
this is more of a medium release. The testing is light. Release can be light or medium. Heavy release, like Rolfing, I'm not a fan of.
Why not?
It hurts too much.
Oh.
Or it used to in the 70s. I don't know what it feels like now. I've been Rolf since the 70s. That was basically sadomasochism.
They lighten up a lot.
They lighten up a lot, right? Because they almost drove themselves out of business. Because they were killing
Some people
people.
just felt like that.
Some people like that shit, but you know, not I. No. And then Alan Wood, right over here. Raise your hand. Alan Wood teaches ART, which is active release technique, which is a great release technique in combination with NKT. There are many release techniques out there. Okay? Do the one you like. Do the one you know. Do the one you're qualified to do.
So you're just applying pressure until you feel
Or
something
release.
give?
Yes.
So in the case of like a movement teacher,
Yes.
would this be where we refer? If
No.
we have
No.
like- 'cause-
You could take a therapy ball and do the same thing. That's legal.
Okay.
As long as your hands aren't touching, it's legal. It's all bullshit, but what are you going to do? That's just the law. Oh. Okay, good. Got the release. Breath in and out, and meet my pressure. There we go. Scars.
So what's your diagnosis?
Release the scar.
But it's
Activate
just a
the
scar.
abs.
You're not like isolating.
I think he's going to die eventually.
So it's just the vectors creating this.
Yeah, the surgery
This is
created.
myofascial.
This is the after effect of surgery. And you will find this on everybody who
So
has
it's
had
not
surgery.
related to any muscular
It weakened his abs.
on the rear. I mean, on the posterior part of the body. There's
No, I was testing the front.
It could,
That was a-
it could have had it could be creating some weakness on the back. We didn't
It
check
could create, I didn't test that. It could create weakness on these muscles here as well. Absolutely. But that's not what I tested.
Okay.
Yeah. But I'm not going to test his back muscles when he's prone because that's too hard.
Yeah.
Okay?
Yeah.
So turn over. We'll show yet another test. This is for the lumbar multifidi. This is a functional lumbar multifidi test. All right. So I'm going to have him push both heels down into the table. Okay? Meet my pressure. So the answer is no, they're functioning. The abs were not.
Maybe because you did the release.
Right, maybe because of the release.
It could have been secondary. Who gives a shit at this point, right? It's fixed.
But
All
also,
right.
also you would want to retest after the release.
Yeah. Well, I did retest the abs, and they were strong. So, Tanya, good question. And almost everybody I see has had back surgery like that, abs aren't working. So unless they're specifically complaining about multi-level back pain, right, which he was not, I would test the abs.
So you're specifically, would be transverse abs? I mean,
There are any number of things you could test. I'm just doing a general test. Don't worry about the specifics yet.
okay.
Trying to go over the SCAR protocol so you can get it. Okay?
In this situation too, I've also had mesh across here.
Yes.
So, if being that we were testing that, would that also be?
The mesh
you got
could-
them to turn on, so that's all that.
The mesh
matters.
could affect the abs as well. of
Yeah.
course.
Okay.
What's mesh?
But you would. This would be because this is where the primary. This is where the pain is. I don't have any pain associated.
Yeah, yeah.
Okay.
But then again, I never took a history and didn't do a
Right,
movement
right.
assessment. I'm shooting in the dark here, folks, just trying to show you protocol, right? Okay, good.
So
Very good.
Excuse me,
Okay,
his exercise would be, homework would be ab exercises?
release the scar on the left in that vector,
Right.
and then do ab exercises. You're right.
What kind of scar release homework do you give him? Have you just rubbed that area?
No. Release it on the vector, just like I just did.
And there's abs, there's like, that's so,
Yeah, well, there are a lot of ways to give ab exercises. It would be the one that worked for him that didn't disturb his lower back. So you have to figure that out. Okay? All right. So that's scars. That's scars, and you can apply that anywhere in the body. Okay? That's the basic protocol. Scars are always facilitated. So you don't have to worry about directional testing and relational compensation. Just go for it. All right? Got it? Okay. Okay. So we did some range of motion testing, comparing her right and left shoulder, and we saw that the right shoulder was limited a bit in flexion, abduction, and active internal rotation, meaning arm behind the back. Okay? So we're going to look first at the muscles of scapular stabilization and see how they do. So we'll test mid-trap, breath in and out, meet my pressure. Nothing. Lower trap, breath in and out, meet my pressure. Nothing. We'll test the lat. So you turn it in, because it does internal rotation, it does adduction, and then I have to pull it up on an angle like that so that I get flexion instead of extension. So it does adduction, internal rotation, and extension. Breath in and out, hold against your side. Nothing. Okay? And then serratus anterior, actually I need you to sit up for this and face that way. So Michelle can see this in the video. Okay? The pinky aims for the belly button, and we're going to do a very short range of motion like this. The reason we do it seated is because when she lies down, the scapula goes against the table and it gives this serratus extra stability. We want to take that out of the equation, all right? So I'm going to test here. I'm going to put my hand on the scapula, and we should feel it rotating like this when it engages, okay? So breath in and out, meet my pressure. That's hard for her to do. And then come back with your thumb on the same diagonal and meet my pressure. No. So none of her scapular stabilizers are effective.
Can I ask a question?
Yes.
Usually doing the line of fibers, but isn't serratus anterior like this? So why isn't it more forward?
We're doing the rotational component of the serratus,
okay.
not the scapular stabilization.
Got it.
Good question.
Oh, good.
So think about it going this way and this way.
Downward,
Then the
upward
fibers
rotation.
line up with the test.
Okay.
Yeah. All right, so lie down. Okay. Now remember, we said that the pec minor was the likely cause of all this, right? So I'll TL, but these are all weak in the clear, so we have to do directional testing, right? So let's see if we can find, I generally like to start up by the coracoid process and then work my way back from there. Anything sore in there? Here? Which is less fun?
They're about the same, really.
That one there. Breath in and out, meet my pressure. Good. And meet my pressure. Good. And then here. And meet my pressure. Meet my pressure. Yeah, I had to move it down a little bit for that one. That's probably a better spot. And then sit up. Switch my hands here. Get your arm up. Yeah. Here we go. Like that. Okay. Breath in and out. Meet my pressure. And back and meet my pressure. I'd say that spot works. Okay. Now we have to test the pec minor to complete our directional testing. So roll it up and in. No. Just roll your shoulder up and in. That's it. Good. And then we'll retest here and meet my pressure. It stays weak. So pec minor is facilitated. Okay? Which is what you're going to see like 90-something% of the time. Once in a while we find an inhibited pec minor. So if in class today you find one, send up a flare. We'll want to see it, okay? Because it's a rare occasion, but we do see it, okay? The smile tells all, doesn't it? Yeah. She suffers with a smile. It's not bad, really. Okay. And beat my pressure. Beat my pressure. Good. Let's see how the lat does now. Beat my pressure. Good. Sit up. And meet my pressure. Meet my pressure. That's good. And now stand right there. And let's do the range of motion again. Bring your arms up. How does that feel?
Much better. Wow.
Adduct.
Wasn't the right one the worst one first?
Yes.
Yeah. Totally
Now
changed.
go up towards your ears, please. You look at the right one's even better than the left one.
Yeah.
All right, turn.
So this one.
Turn backwards so she can see. Put your right arm up. That's better. And now the left arm. That's pretty comparable. Okay. Excellent. You can stop. You going?
Yep.
Okay. So what? Go ahead and do it yourself. Okay. So there's a hard stop on the right. Okay. So we need to know why there's a hard stop on the right. Okay. So let's test. So aim your palm to your belly. Meet my pressure here. Okay. Subscap not working. Meet my pressure back there. That's working. Come forward like that. Definitely not working. Meet my pressure. Okay. And then here, she's going to come out a little bit. Meet my pressure. And that's not working too well either. So we have infraspinatus and teres minor in the clear, okay? Subscap and supraspinatus in the clear, not okay. But that just tells us there's dysfunction in the system, right? Okay. So what's the functional opposite of the subscap? We have two. In this position, it's teres minor. In this position, it's yeah, but that's formulaic. Let's see what happens, all right? So, now I'm going to go onto the back of the shoulder blade, and I'm going to palpate, that's okay. I'm going to palpate teres minor, which isn't obviously inferior to the infraspinatus. That one. Infraspinatus lights up. Okay. Meet my pressure here, towards your belly. That's better. And towards your belly. That's good. Does it affect this one? It does. Oh, it's a threefer. All right, we got a threefer on this one. All right, so we know that there's relationship between the infraspinatus and those three functions, right? Now, I have to test the infraspinatus and then retest, right? So, meet my pressure here. Good. And then come here. Still weak. Meet my pressure, still weak. And meet my pressure here. And it's still weak. Okay. So we have our 80% NKT, started weak in the clear and stayed weak, right? So what's facilitated? Infraspinatus is facilitated, yeah. And you know you have all these little nasty spots. Where are my NMR guys? There, right there. You're a neuromuscular therapist, right? That lovely infraspinatus trigger point is what I'm on right now.
Is that just below the spine?
It's kind of right in the center of the shoulder blade. Pretty much it hurts on everybody. It's a nasty little spot. But useful.
Very useful.
Right? It's great for all kinds of shoulder problems. Okay? And let's see if it's improved some. Meet my pressure. A little better. Okay, meet my pressure. Good. Keep my pressure here. That's also good. And now let's watch range of motion. Go ahead. Compare it to compare it to the other side. So go ahead. That improved quite a bit, right? And that was just with a little bit of work. Okay? So a little bit more release on the infraspinatus and she'd be good to go. Everybody got that? All right. So that's what we're going to practice now. Ready? Okay. So Daniel had, did you separate the AC joint? How long ago?
10 years ago or something.
Yeah? And what have you felt in your shoulder since?
What I felt in my shoulder?
Yeah, since.
It's been fine.
Been fine?
Yeah.
Not unstable? Hard to tell.
Hard to tell.
All right. So let's look at these tests here, okay? So thumb to the opposite hip is pec major sternum. I meet my pressure. Negative. And then back of the hand towards the opposite shoulder is clavicular. No. All right. How about rhomboid? Breath in and out, meet my pressure. That'd be strong. Okay? So those guys have a relationship. So I'm going to TL on the rhomboid and see what happens to the pecs. Okay? Here we go. So we're back here?
No, right there.
Everybody here? Okay. And aim your thumb for your opposite hip. Aim the back of your hand, your opposite shoulder. I'd say that improved a bit. Okay? Now we had directional testing, right? So press down here. Good. Back to pec. Meet my pressure. Stays weak. Pec clavicular, meet my pressure. And also stays weak. So whatever starts weak and stays weak is? Inhibited. So what is facilitated? Rhomboid. Okay. This would be the push-up formula. This is the common push-up presentation. Okay? A little release on the rhomboid. Lots of people have pain in the rhomboids, right? No. Never heard of that? Never. Some shocking breaking news, Sarah. Rhomboids can be painful. No. Stay tuned for the 6 o'clock news. Yes. Okay. And meet my pressure. And meet my pressure. That worked. So what's your homework? Release the rhomboid and strengthen your pecs. Yeah, that was too easy. All right, you can stop. One in on her shirt. I told her she should change deltoids. So this is kind of a functional anterior deltoid test, which she's going to fail. Okay. You can also bend the elbow and have her come up this way for anterior deltoid. That's better. Okay. Middle deltoid. You're going up this way into abduction, meet my pressure, absolutely nothing. And posterior deltoid is down this way, meet my pressure. Whoa! Not too good. Not too good, not too good. Now you have rotator cuff problems? And you think it's your supraspinatus that's overworking? What do you think? Teres minor. Yeah, we found her teres minor before. Her teres minor is lit up like a firecracker here. All right. So teres minor, right? You find that bottom part of the triangle here, and it's right along the border here. Okay, so we walk our way here and see if we can find some.
No, got it.
Yeah, she's rather expressive when you actually do find something. All right. Okay, I'll meet my pressure. Good. And meet my pressure. Also good. And meet my pressure. Wonderful. Okay. So this spot will work. Now remember, they're all weak in the clear, so we have to test teres minor again. Meet my pressure. Good. And here, still weak. And here, still weak. And here. So whatever starts weak and stays weak is good. You can't say that too many times. All right. Line your side. We'll get that spot again. Right about here. That one right there. Okay. So kind of right in the belly of the teres minor. The teres minor of the 4 rotator cuff muscles is the strongest. So if the others go, this is your default stability for your shoulder. So even though it's the smallest of the 4, it packs a mighty punch. Okay? As Thomas said, it's kind of like the popliteus of the leg there, you know. Small but mighty. Okay, line your back. And meet my pressure. Good. And meet my pressure. Excellent. And meet my pressure. Beautiful. Okay. So when large global muscles go off and small stabilizers have to work, no bueno, right? Okay, let me try it again. So in Greek, bicep means 2 heads. That's exactly what it means. Sep means head, bi, tri, quad, right? They were very creative with these names. God help us. All right. I wasn't there. Don't blame me. I wasn't there. All right. So the bicep really should be 2 different muscles, but it's one. So you got the short head, which attaches to the coracoid process, along with the pec minor and the coracobrachialis. And then you have the long head, which comes up through the bicipital groove, goes into this notch right in here between the lesser and greater trochanter. Okay? Tubercles, I mean. Lesser and greater tubercles of the shoulder, not trochanter. Okay? And then it passes through and blends in and becomes the superior labrum. So the long head of the bicep actually is the support of the superior labrum, and the long head of the tricep is the support for the inferior labrum. So problems with long head or of either bicep or tricep is you're gonna have labral problems. Okay? So when people tear their shoulder labrum, there's clearly that they have problem with usually with the long head of the bicep, which has a tendency to go out of its little groove here and move medially and start rubbing on the lesser tubercle, and then it gets tendinitis. That's called bicipital tendinitis right here. And if it stays there and rubs and rubs and rubs, it can actually break, and then people end up with a unicep instead of a bicep, right? They get that big saggy bulge down here, right? So this is the process of how it happens, okay? So why does the long head of the bicep come out of the groove and only go medially? It never goes laterally. Well, this is called a lesser tubercle, and this is called the greater tubercle for a very good reason. The greater tubercle is bigger than a lesser tubercle, so of course the bicep would be pulled this way, but more importantly, it's because of all the internal rotation that people do with their shoulders, right? Internal rotators, pec minor, bicep, short bicep, coracobrachialis, pec, subscapularis. It's a giant mess right here, okay? And we have initials for this area of the body. the UCF. We call this the UCF. Holly's, of course, dying for me to say what it is. Say it with me now, Holly. Upper cluster file. There we go. Also affectionately known as the UCF. So on the scholars page, you'll see this referred to as the UCF. This down here is the LCF. Okay? New Yorkers named this, not me. All right, don't blame me. Okay, so the UCF, when something in the UCF is pulling too hard, it's going to turn the shoulder in this way all the time. And for some people, that actually dislocates the long head of the bicep. It comes out of the groove and ends up on the lesser tubercle. Owie, owie, owie. It also causes this speeds test to go weak and all sorts of things start to go on. But it can make a shoulder very dysfunctional. And does it show up on an MRI? It sure does. Sure as hell does. Yes.
Show us how to put it back in.
I'm going to show you how to put it back in. I am indeed. Okay. So, this is one of the most common shoulder things that I see, and it's diagnosed so poorly. It's horrendously diagnosed. And they tell people all kinds of crazy stuff, right? So, let's take a look at it, shall we? Anybody volunteer for this one? Who thinks that? Michael, you got that? You might have it. All right, we'll find out. Come on over. Anybody else think they might have it? What do you stop? You've used up your shoulder quotient here. Okay. So let's look at the test for the biceps here. This is the humeral flexion test. There's also an elbow flexion test. I'm not interested in elbow flexion right now because I'm working on the shoulder. So meet my pressure here. Okay. And come over here. Now this is long head, right? Because it's more abducted. And meet my pressure. Adios. So he's a candidate. Okay. Let's compare that to his other arm. And we'll do long head here. And meet my pressure. Yeah. Are you right or left-handed? Right. Yeah. So his dominant arm has a weak long head, so that's significant, right? Okay. So this is coming out of the groove. If I just simply try and put it back in the groove without correcting the biomechanics, how long would that last? Yeah, just go right back in until he used his bicep again, right? Or misused his bicep, right? Okay. So then we got to go into the UCF here and see if somebody's lit up. That's lit up. Okay, you'll TL it, and hold your arm up, beat my pressure. Yep, that worked. Now we have to test here, so we'll just kind of do like a pec minor test. Roll your shoulder and meet my pressure. Good. And we'll come back here, meet my pressure, and it stays weak. So whatever stays weak is inhibited, right? So we've got to release here first. So we release here because the internal rotators are overactive, right? The long head of the bicep actually helps to abduct the shoulder. Interesting, huh? Because it helps with external rotation, which gets you into abduction in the shoulder.
I have a question.
Along with the subclavius, that helps with abduction in the shoulder as well. All the little muscles they don't tell you about to do that stuff, right? Yeah.
So when you're doing the manual muscle or the testing of the long head of the bicep,
yes,
and it's weak in the clear,
yes,
will you automatically assume that it's out of its groove? Is that
no?
Is that
I don't automatically assume
okay.
that.
Do you palpate to find that out?
I will in just a minute.
Okay.
Yes.
All right.
Miss Segway. Mrs. Segway, I should say. Yeah. What's that, Mark?
I was just wondering if it also helps with supination.
Yes. Yeah. Of course. Together they do supination. Individually, one does adduction, one does abduction, one helps with internal, one helps with external. So sometimes they work together in supination, and sometimes they oppose each other. That's what drives me crazy about the names, right? How can a muscle in itself oppose itself?
Like adductor magnus?
Huh?
Like adductor magnus?
Adductor magnus should be two muscles, of course. It shouldn't be one muscle. But I didn't name these things, right? Breath in and out, meet my pressure. Wonderful. Okay. That does not put it in the groove.
Okay.
All right.
I just wondered if the positive test for knowing that it was out of the groove, what that is.
It's a possibility.
Okay.
But you have to palpate.
Okay.
Yeah. Okay. So Michelle, can you see over here now? Okay. So everybody get close on this one because you want to see this, right?
Sorry. Sorry.
Okay.
All up in the space.
You have been circumcised, right? Good. We don't have to do that again. We don't have to do that again.
I wanted to share that with you.
Okay. So if you go up the middle of your bicep with your pinky, the edge of your pinky, you'll end up in a groove right about up in here. You feel that little groove? Okay? Go back and forth, way up higher. You go in that little groove and you flex your elbow like that and you move. You should feel a tendon popping out under your finger. Okay? If you don't feel a tendon popping out under your finger, you may have a bicep problem, okay? So I'm going to go up his bicep. Here's the groove right here. Go right here like that.
Is it tender? Yeah.
There's nothing there. Then I'm going to go medial to that, and that's where he lights up. So his bicep tendon is here, and the groove is here. That's how far out of the groove it is. I've seen people all the way over here. That's a serious out of the groove, all right? So this is about what, 1/4 of an inch or something like that, okay? So it's out. And he's, you know, you're going to have pain right here.
I called it.
Huh?
I called it.
You did?
Told
You were right. You were good. Yeah.
Does
You
the
get-
uterus look more interior than it should be?
Not particularly. Okay, so you get your second and third fingers on the medial border of the bicep tendon, and you push it laterally towards the groove. At the same time, you take the arm and internally rotate it so that the groove gets closer to the tendon. So it's two things at the same time. Women are better at this than men. Two things at the same time.
Multitasking versus monotasking?
Exactly. We're good at monotasking.
No time.
So I'm gonna. It's a fairly, a good amount of pressure to get it over the lesser tubercle. I'm gonna go slowly. Now watch my fingers as the tendon starts to go over the tubercle. Did you see that little jump? That was the tendon going back into the groove. Okay? Now we'll test this. Meet my pressure. Strong, very good. And now I'm going to go up and find that little groove right there and put my finger in here and go back and forth. And there's your bicep tendon. You feel it? Now it's going to be sore. So after you adjust one of these, they have to ice it and take some anti-inflammatories. It's going to hurt. Because I just took an inflamed tendon, pushed it over a bone, and put it back in a groove. That doesn't sound very good, does it? And it's not. But eventually, of course, it'll be wonderful. But in the short term, there's inflammation. And when there's inflammation, I mean, some of you may prefer Zyflamend or turmeric, but you got to take some, come on. Take 2 Aleve twice a day for a couple of days and you'll be all good to go. All right? I've tried all the natural anti-inflammatories and good God, Aleve works so much better. All right?
Do you have to keep it immobile?
No, you don't.
Anti-inflammatory, so it doesn't.
No, you don't have to. Don't immobilize it.
Well, I'm just saying because sometimes the
all right, you can
inflammation
stop.
is good to keep it.